هاي موجودة على موجودين البرزنتيشن.
So, okay, to get started, Anne mentioned it. During the week, we are going to cover quite a few of the building blocks of the routine information system. And we are going to get started with the CHIS. So as the list with all the abbreviation, we are talking about Community Health Information System. The main objectives that I would like you to bring home with you is like understanding a little bit, like, of course, we will show you a little bit what we have already in the system, the toolkit that is part of the community health reporting system. Some considerations on when you are thinking about integrating health, community health into your routine information system. And of course, the benefits of integrating this kind of data alongside with your facility data. And of course, what comes together with bringing everything together, it's triangulating this kind of information. So I will just show you a quick example of an implementation that happened, just let's say as an inspiration for further analysis. So what is actually a CHIS? A CHIS, you see here, there is like quite a lot of things going on in this diagram here. But overall, a CHIS, it's a combination of different things. You have your paper-based things, you have your more technological side of things, and then you have, of course, all the people that work with it, starting from your community health workers, up to your district and national reporting systems, and of course all the processes that come in between, because you have to realize that we are starting here with the lowest level of reporting. And we can report what? We can report population data. We can report, of course, all the kind of different health information that you might be doing. So any kind of like a health service that you might be providing to the community. And of course, you can also check stock. As a matter of fact, when you bring everything together, you might also want to have an overview of the stock, because sometimes, let's say, if you're doing malaria services in the community, you might want to know, let's say, how many rapid tests you might have. Same thing with HIV, same things with other NTDs, and a quick test that you can do directly in the community. And of course, all the system that goes alongside with it. So I'm talking about data flow mechanisms, but also workflow mechanisms that have to kind of seamlessly overlap, but also seamlessly overlap with what you're already reporting at facility level. And here you see it. I mean, it's a simple idea, but it takes a lot of work behind it. You have your community level, and it has to go all the way up. And how do we bring it all the way up? And how do we seamlessly bring it together in order to overlap and make sense out of the community data together with the facility data, in order for of course, that at facility and community level to manage your activity, but also for people at higher level to understand what is going on and to see how the activities are having an impact in your community and in your facility. So integrating system, I mean, this is like a very general slide. It could be applied for a CHIS system. It could be applied for other systems as well that you might want to bring together to make sense of a general health information system. So you might want to define the scope of the system itself. In this case, we're talking about community health workers and the data that is collected through the community health workers. All right. And you need to identify the data elements, because we said it, we want everything to fit all together, and we want these things to work in parallel. So you might want to check what you're collecting at facility level. You might want to check what you're collecting at community level, and make sure that these things can overlap and feed into each other. So let's say you might want to say, okay, I'm collecting, I don't know, how many cases of cholera in the community, but then if you're not reporting them also at facility level, what kind of sense are you getting? You might having just one side of the picture, or if you're collecting the information on cholera in the community, but meningitis in the facility, what kind of added value are you having? So you need to plan together to see that everything fits together in the time of reporting. And then you need to develop the data flow, because especially when it comes to community data and health and community health worker, every country has a different system, a different way of applying this kind of reporting system, and most importantly, activities that are run in the community. It might even be that different people run activity in the community. In countries, it might be community health workers that have no medical background. In other countries, the community health worker are also nurses that simply get detached in more outreach mode and get to visit the different community. So it's very dependent on the country, but nonetheless, it has to fit with the reporting system. You cannot just bring in from the top and expect them that everything fits along with the way that they are working. So it has to be very well thought through. And of course, at the end, it's implementing the system, which sounds very easy on paper, but it's the most difficult side of things, and it takes a lot of time. But if you start with like the very basic points, 1, 2, 3, you have already a strong background when it comes to implementation. So here I'm going to start to give you a quick overview of the community health toolkit that we have already developed within RHIS, and we have done that in collaboration with the WHO, with UNICEF, and it's a very large, it's a very comprehensive toolkit, but as you will see, it's very modular, it's very flexible, depending on the kind of activities that are run in country. And as we were saying before, we need to start choosing. This is more side of like point 2 and 3. So you need to identify the data elements, and you need to make sure that it overlaps with your reporting system. So here we find a bunch of different, wait, let me check if it works. Yes. So here you see that there are like a bunch of different services. It might be nutrition, malaria, TB, HIV, WASH. There is like a huge variety of things that can be run at community level. Pick and choose what is useful for you, what it makes sense for your kind of activity. And of course, downstream, it all comes together. So you scan what your relevant indicators are according to your national guidelines. Of course, as we were saying yesterday, there are some international guidelines that we work all together with our partners to bring to you, but then you have to make sure that these international guidelines also fit with your national guideline. So in some cases, it might be the case that these global indicators will have to be adapted at local level. So it might be disaggregations need to be adapted, naming might need to be adapted, but at least you have a general framework that can kind of guide you through. And then you start with what is your core indicator, at least to get started. We were saying yesterday as well, start with really with like what you really need to get out of things. And then as capacity increases, as resources increase, you can start adding up, but start really with your core indicators and your core activity. And then you start checking, as Anne was saying, like it's impossible to start checking the quality of the data if you don't start using the data. So you start some kind of like iterative process for which you start checking your data, you start checking the quality, it goes through some quality checks. And then we'll see this afternoon also with like some design principles that can help you with this data quality check. And of course, you start checking your final choice of indicators to match your workflow. Here you see, we were saying earlier, it's very extensive. You see here, like 372 data elements. No one is expecting anyone to collect 372 data elements. It's because you will see, I will give you a very short example, but still, some of these data elements are scattered and found in different data sets. And it depends very much on what kind of activities your community health workers are doing. So you see here that these are all the modules that we have. So they cover pretty much most of the activities that you might run at a community level. Some of them are at monthly reporting, some of them are yearly, and all of them, of course, come with a dashboard that can be adapted, can be uptaken, can be completely ignored because you want to do your own dashboard. It's up to you. Mohammed was saying yesterday, we give you the wheat, we give you the flour, you make up the bread as you like it. You can add spices to it, you can leave it plain, you can make it square, you can make it round, and you can do whatever you want. So modular approach, we were saying it. We have all these together, but you can pick and choose what is needed. And this adds a little bit of flexibility. Why? Because it's a global toolkit. So we cannot foresee and like kind of read into people's minds about like all the different combinations of activities that you might have in the community. But with this like modular idea that you can pick and choose and combine depending on your activities, you can build up your own data sets in order to overlap with the activities that you're running in the community. So for example, as I was saying, we have like more than 300 data elements. We do not expect to have these data elements everywhere. But for example, here is just like a silly example that I just extrapolated. But for example, here, these are like people assessed for mental and neurological conditions, so mental health stuff. This data element specifically is found already in all these data sets, okay, with different disaggregations, with different frequency. It's very much up to you to decide, okay, but my community health workers do mental health evaluation when they go for maternal health checks. So that's exactly where I want it to be. I don't care about when they go for HIV, NTDs, disease neglected tropical diseases, just so you get acquainted with all the abbreviations, or adolescent health. Or maybe your community health workers have a program that is purely mental health, so you don't really want to have it also when you are collecting the data about these diseases or this particular target population. It's very much dependent on country. We've seen like a huge variety of combination. And so you can pick and choose and put them where it's relevant. And of course, you have like so many implementation considerations. We are going to go through them also with Anne, with Olav throughout the week, but still just to like put you a little bit in the mindset of having to evaluate what is really important to you, what kind of like activities you might want to do. I don't expect you to go through all the points right now, but just to give you an idea, like how are we going to collect these community health data? Are we going through paper? Are we going through mobile? Do we expect to aggregate them at facility level? Are we constructing a separate hierarchy that is just for the community? Because community is, yes, it normally refers to a facility, but nonetheless, it can be split in different sites as well within the community. So do we want to start straight away countrywide, or do we want to start with little pilots and then start scaling up? Or for example, how can we triangulate some data once we have the community data? So these are all little considerations that you need to start thinking when you are implementing and considering how to bring together all this kind of information. So this is just a question. Some of you might not have a community health system already in place, but nonetheless, most of you probably have nonetheless some community data or community activities going on, be it, and when I say community, it could be also simple outreach, or for example, in some cases, community also takes the name of mobile clinics in some cases, because that's the kind of community activities that you're doing. So I'm just like asking overall to you, like what kind, how can the parallel CHIS reporting into HMIS, how they can improve the health data? Just like, I don't know if you have some idea, like what kind of like outcomes you might have when you start integrating the data together. Yeah.
Thank you. Maybe I can just answer by giving some examples.
Mm-hmm.
I remember one time, one of the countries we are supporting had a separate system instance for community health workers activities data, and then for data for starting from health center upwards to the hospital, there were another instance for that, for aggregate. And there are some activities, right? Let's say, for example, malaria. There's some package of malaria treatments provided at community level by community health workers. You see that we do have some data for malaria being reported in a separate instance for community health workers. And also have the same data elements being reported for those who have been treated for malaria within the facilities. So for someone, a program or anyone in subnational level who wants to aggregate malaria data, maybe for district, for country, he will need to have a total, but to sum up those number of cases treated from community and those treated from facilities. You know, you see that it somehow had to have a kind of sum up or totals by combining data elements from different instances. So that can be an example. And then we decided to advise the country to put together those two instances so that we can have one instance. All data elements for malaria within the same instances. Within the one instance. And from there, we have been able to calculate denominators, numerators, indicators, coverages, mortality and morbidity rates for all those indicators. I'm giving that for malaria, but we do have different examples. Thank you.
Thank you very much. So here we're talking about data quality and also added value of bringing things together, like population data, as he was mentioning, but also checking that your activities are running smoothly and that you're achieving your targets as well, for example. Anyone else? What kind of like a benefit could have?
Yes, so we have the vital statistic registries in Egypt, and they're already up and running, and that will bring us to the immunization. But linking these data together with family planning, we have a big population problem, so we can target the women straight after delivery. It will help the community health workers to streamline their search for who to target to improve the family planning program.
Absolutely. And we'll see that case also later on with the CRVS presentation. It's one of like the key entry point in the end of babies for like with the immunization and with birth and with all the activities of family planning. So we will see it later. So yeah, all the benefits in the end are always the same in the end. We have improved data quality. We said it, community health workers and community data is the lowest point that you can get your information from. So bringing it all together, you have more comprehensive database and more integrated data. And that's what also Jean-Paul was mentioning. You bring it all together, it's more comprehensive, and you know that you can have your totals. You can have improved accountability, because of course, if you have more data, your data is more reliable, you have the good totals and everything, you can actually start making decisions. If you are missing all the activities that are done in the community, how can you make decisions if you are missing, let's say, half of the activities that you're running? Of course, also efficiency. We were mentioning yesterday as well, like when you start digitizing and bringing everything together, the reporting time and the feedback time that you are receiving for this kind of activity, it's fundamental for the quality of your data as well. If you are just reporting this data and these numbers just fall into a vacuum and no one really checks it, what kind of added value there is then for making choices to improve the data quality? But most importantly, if there are problems, how fast can we receive this kind of information that there are problems or that we are not finding the right people, let's say. So it's also a matter of efficiency of bringing everything together. And of course, data use. it's all like a, I don't want to call it, it's like, it's a circle in the end. You start bringing it together, you start using it more, you start improving your quality. So it's a circle that kind of feeds into itself in order for you to start bringing everything together and start analyzing this information together. And talking about information together, this is an example that I took from an implementation in Chad. So they were trying to find zero-dose children. But to find zero-dose children, they had no idea how to do it from the facility alone, because in the facility, what you might do is you might check missed opportunities for vaccination. And by missed opportunities of vaccination, I mean, you have a child and you let it go. You are not checking whether this child has been vaccinated, whether this child has received all the important ones for the age this child is. So this is what you can get from the facility. But how do you know that maybe out there, there are also children that have never received a vaccination at all? And that happens. So at first, like they had surveillance and EPI data. EPI, it's routine immunization. It means expanded program for immunization, just for people who are not acquainted. My fellow engineers there. So EPI, it's a routine immunization, just in case. So they were bringing in everything at facility level, and at facility level, they were seeing that yes, we still have some coverage problems. We still have some cases that are popping up of vaccine preventable diseases, but we know more or less where they are, and we know that it's still ongoing, and we're trying to improve whenever children come to the facility. But then they're like, okay, but why don't we go a little bit lower? So we went a little bit lower, and we are starting to implement the same modules, but at community level. So we have now community health workers going around household to household within the community to check which children have received the right vaccine, whether there are children that have never received any kind of vaccine, and whether there are still pockets of vaccine preventable diseases that afterwards start to kind of like come up and can cause an outbreak that then at facility level will be reflected in the volume of activities nonetheless. So for example, just to like, when you start bringing data together, these are just simple maps that I have taken from our demo site, but you start bringing your community data and your facility data together, and you start noticing that things don't necessarily overlap. And you might want to like start investigating why these things do not overlap. You see here, for example, like you have your BCG coverage. From here you have like the big ones, like the administrative like delimitations from routine health facility data, and the little circles are coming from community data. So for example, here you might have administrative data from facility, amazing coverage, more than 90%. We are doing great, guys. Then you have people going down to the community, and they come out with we are lower than 60%. So what do you do? I mean, either someone is picking data at facility, either we have a problem at community data, but nonetheless, these things are not overlapping. And you will never find out that they are not overlapping. And you will always have just the beautiful green area that kind of like makes you all happy. And you will never know that maybe there is actually a problem in the community, because you don't know. You only have the reflection of the children that come to you in the facility. But there is maybe a lot of children out there that you're not aware of, and they're not coming to the facility. And that is not just for immunization. It could be for postnatal care. It could be for family planning as well. It could be for any kind of activity out there that you're doing in the community. And as a matter of fact, here, cholera cases, in some cases, it overlaps. Great, fantastic. We're doing like a good job. But then you have like for example, here in the facilities, you're seeing that no problem whatsoever. And then you go in the community, and maybe they're not confirmed cases, but nonetheless, there are some suspicions, and it's quite a high suspicion of cases out there. So you might want to go and send someone to start checking out with your community health workers whether this information is true, or whether you need more information to the community health workers to learn how to identify these cases. But nonetheless, you will never find out if you don't have your community data coming along with your facility data. Most importantly, for example, we start drilling down. We're talking here about coverage. And I think this is measles and rubella. I don't see that far. Yeah, am I wrong? Measles and rubella. So you have, again, your administrative data that it's green. You're covering everyone for more than 90%. You have here, actually, I remember that this district here was at 91% coverage. And you're like, fantastic. You're doing an amazing job. And then you go down to the community and, well, turns out that you're lower than 60. So what is going on? You might want to start using maps a little bit to start checking out what is going on. And you see, so here I have like a layer. They are like the same layer. I'm just showing it in different ways, one with a bubble and one with just the area. And here just to see whether they match the same color. They don't match the color. So I might want to go a little bit lower and I start checking with another layer, where are my facilities? And do you remember yesterday that I was showing you that you can map your facilities and you can start checking where your facilities are, what kind of population they are covering, what kind of like distribution of population, be it by age, be it by sex. You can start checking this kind of information directly from your maps. And so you start seeing, okay, so these are my facilities in this, be it a province, be it a district. It can be any kind of administrative subunit of the national system. And you have all this information here. Here, you will see later on when we start checking more triangulation information. Here you have a scatter plot that can help you telling whether you have problems of accessibility or whether you have problem of use of the facility. So you might start wanting to bring in your community data, checking your coverage, but you also want to start understanding how these facilities are used. So for example, here, if you have like, for example, a high coverage and a low dropout, so people are showing up for their second or their third dose, their fourth dose, depending on what vaccine we are talking about. But in this case is measles and rubella, so 1 and 2. So you see here, you have a high coverage and a low dropout. So a lot of people are actually getting their second dose as well. Here, you start having a high coverage and a high dropout. So it might be that they're not using it well. Why? Because they're getting their first dose, but somehow, for some reason, they're not getting their second dose. So you might want to start investigating why they're not coming for the second dose. Here, you have low coverage and high dropout. So this is disaster zone. They are not coming for the first. The few that are coming for the first, they are not coming for the second. So what is going on with those facilities? And here you have low coverage and low dropout. And here you might have access issues because those ones that are coming in the end are managing to get their second. But still, we're not at the level where you want to have everyone with both of them, of both doses in this case, but in any case could be any vaccine. So I highlighted two just to give an example. And one facility of the ones that we were putting in this map here, one facility it's up here, so it's having access and utilization issues. And one facility is low coverage and low dropout. So this is where you start triangulating all your information coming from the different sources. So turns out that this facility here is one up here, and this facility here is one down here. This facility up here has 80% coverage, yet we were saying it still has a lot of access and utilization issues because we have the scatter plot showing us. And this one down here, it has a lot of access issues because we're having low coverage, but also we are having low dropout. So the ones that are coming, they're still trying to get their second, but we're not getting to enough people. So this is just an example, but for example, then you start, let's say with the lower facility that you're saying, okay, we have like very low coverage. I really want to improve that one. You start checking all your communities, for example. And this is just a silly example, but there could be like 100 reasons behind it. Every country, every zone, every district could be completely different for different reasons. And then you start drilling down and it turns out that the communities around the facility, yes, they're showing up because it's like 10 minutes by car or motorbike or bicycle, depending on where you are. And the ones that are out here, are actually disaster. There is no way to get to the facility. So the few ones that actually that 60% chances are comes from the ones around it. But you will never know that these ones you don't even have data. These ones are terrible coverage already, but you need to start drilling down and finding these facilities and these communities. So here it was just like an example of an implementation that we are carrying out with Chad. And so we have started with the facilities. We have started finding those facilities that have some access, some use problems, and we are starting to focus on those communities to try to understand why these communities are having these problems. So this was just a quick example, but I think that like that could give you a good idea of like a practical use of your community data. And then finally, because we are covering also this kind of off topic later on with Olav as well in the session about census data, survey data. But nonetheless, this is very important when you are talking about community data as the population and the impact that your community data can have on population. So we are going to go through this again, but normally these are your sources of information for your population, be it census, be it estimations and such. But many countries might delay either for disasters, wars, problems of budget, and you simply are continuing to base yourself on old census. And the rest is just estimations of population growth. And in some cases, these census data are old and the estimations might be wrong. And therefore, what do you have? You might have underfunding because you don't know really your population data. It might be that you think there are 10 people and truth is there are 200, or it might be that you think that there are 200 and you have 2 people. So you end some areas where you have a lot of services and a lot of supply for very few people. And when you really need them, you have nothing because you think that there are 10 people. So you might want to cross-check also the information that is coming from your community data with your facility data, or in general, your administrative population data. And here, for example, it's just a silly example, but it happens and we've seen it a lot of times. In green here, we have the administrative data. So we're talking about estimations. And at the bottom, we have community data on population that is coming directly from the community health workers going and checking how many people there are in every household. And you see that here, in this case particularly, turns out that you have a little bit of a gap here that you say, but it's very tiny. Yes, but we're talking here about like more than 50,000 people. 50,000 people, it's a lot of supply, it's a lot of services, it's a lot of planning. It means that you nonetheless have to have like extra doctors, extra nurses, and all this planning has to come together. And this is just coming by just 2 data sources, just because you have your community and your facility data. And imagine what you can do when you start triangulating community data, facility data, stock data. You have your facility assessment data where you start checking, okay, but in this facility, I only have, I don't know, 3 doctors. And then you start realizing that you have like this 50,000 gap, like 3 doctors, 50,000 people might not be enough in your situation, or maybe it's more than enough in other situations, depending on availability of doctors. But these kind of gaps, you will only be able to find if you start triangulating your data from different sources and by bringing together this data. Without this, you're sticking to your facility data. And what we were saying earlier, your coverage could be fantastic, or your coverage could be horrible, and you will never find out if it's true or not. So that was just like my general idea to give you. And so it's just to let you know that like this process of putting together population data coming from different sources is called population validation. And it can allow you to find discrepancies. It can allow you to improve your planning. It can allow you to improve the accuracy and of course also the engagement, because in the end, when you start engaging more and more with your communities, there are a lot of benefits, because you might start having stronger bonds, which might mean also stronger links when it comes to emergencies, to outbreaks, to any kind of difficulties that they might have at a community level. Summarizing everything, take-home messages from this session is that integrating the sources is not an easy process, but it's nonetheless a process of mapping. It's a process of trying to understand what your core indicators are, where these indicators are and these data elements are collected, who is collecting it, and all the processes around the data collection. The fact that you can benefit from triangulating this information and bringing in this kind of information alongside with your facility data. You benefit a lot by triangulating this data and other data that we are going to see throughout the week. And of course, among the benefits is also an extra layer of benefit on the population side. So these are really the core information that I want really to instill in your brains, because it's very common that population data gets overlooked. And it's very common that population data remains, as Jean-Paul was saying, in a separate instance that gets forgotten because it's community health workers, they're not doctors. But those community health workers are a source of information, and they are trained most of the time to do and deliver basic health services. So let's try to bring everything together to try to have a better overview of your services. So that was my general overview for community data. And I'll take a 1-minute break. Oh, fantastic. Well, I take the break and I switch. Go ahead.
Okay. Good morning, everyone. This is Fatima Hamad, IT manager in Jordanian CDC. This center established in COVID crisis in 2020. One of our strategic goal in Jordan GCDC is promoting and supporting availability and use of high quality surveillance data to guide evidence-based national public health policies and practice. And what we are working on now in JCDC is have a project to make a mapping for all surveillance system in the country. So we are working in this study with more than 34 stakeholders, main stakeholders from public sector, from private sector, from international agencies in Jordan. And what we are working now is the first step to make a kind of gap analysis and mapping for all surveillance system, either they are paper-based or electronic system. And after that mapping, we will start working on establishing a national health information system for surveillance in Jordan. So I think that this will help us a lot, because now we are starting with communicable disease, and we will working then with the non-communicable disease for registries. And I think that when we are looking, one of our the result of this mapping, and now we are finalizing the report and we will publish it, is we find that many scattered health information system in all these sectors, and we find that there is data collected here and here and here, so we can make a kind of integration between all these systems to build the national data warehouse for all the system. So I think that we can work on that, and we can benefit from this to establish the data warehouse, which will help a lot the decision maker in Jordan to take a right decision depending on the evidence-based data. What we find also that we have to work a lot on the legislation, that how can we make share this data between all these institutions, that that there is Ministry of Health, Ministry of Agriculture, many ministries, that you have to work on one health approach. So you have to work a lot first on legislations. Also, one of the main topics we work on is the quality of data. It's very important to focus on this, because if the quality of data is not good, you can't depend on that to take the right decision for the country. So I think that's thank you for your good presentation, and I think that we have to work a lot on this. And the community data is very important, because if you are not focused on it, you will not have a comprehensive picture about the situation in Georgia. Thank you.
No, thank you. And it's a struggle that a lot of countries have, especially when it comes to surveillance data. It's very easy to scatter it along 100 different ways of collecting data that might be also different. It could be like that you have communicable diseases that are divided into, that are collecting the same information, but you have 500 different ways of calling the same information. So already the fact that you are mapping things together, trying to understand what is the landscape in order for you to bring it together, I think that that's already like a core step that we were saying earlier as well, is the really first step that you have to understand how is data is reported, what kind of processes it goes through in order for you to start mapping really all the data elements, all the indicators, and start to harmonize everything for you to start triangulating this information. So I'm very glad that this process has started, and I hope that also that can bring along as well community data, because I'm sure that it will also bring in a lot of useful information as well. So thank you. Yeah. Oh, you sure? Okay. 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 Is there any other, like, could be a comment, could be a reflection, a question? Anyone? Yeah.
Yes, thank you very much, Vita, for such a nice and fruitful presentation. Just maybe we can share our experience in the maybe the first 3 steps, because what we accomplished, we discussed with our stakeholder about the data integration and interoperability between primary and secondary, and we identified the minimum data sets. For example, our case study was the gynecologist and the obstetrician in the hospital need to see the ANC data, and the ANC care provider need to see what happened in the hospital in the GBYN. At that time, we sent for the Ministry of Health to conduct a workshop, and we listed the full data from the forms in the hospital and the BHC forms, and we do mapping, and we do what is called rating, Likert scale from 1 to 5. And we voting for each data element, what you need to see from this side and what you need to see from this side. And we calculated that result and the rate in front of them on the screen on a spot. And based on that, we build consensus that the minimum data sets in the hospital and minimum data sets of primary health care that each one need to see. This is a sensitive point because you focus on that at the beginning of the presentation, and thank you for that, because the define of scope is important. Without define the scope, people will lost, and okay, they will just say something like general scope and very broad. So we need what is called demarcation. So the borders should be clean and clear between the level of place we need to have the data. So we finalize all 3 steps, and now we are in the step number 4. Hopefully with colleagues, just I discussed in the morning with Yuri and Zubair about the importance of step number 4. And just 1 month ago, the Minister of Health asking us in official meeting about where we are standing now in this issue. And okay, we answered, we finalized the architecture and the documents and everything ready for the implementation. And hopefully from the side meeting in this workshop, we will have like some guiding from our colleagues to finalize number 4 and share it with you on the community if that works.
My goodness, please do. And
Sure.
one quick question, how long did it take you to go from 1 to 3?
Really, it takes around 6 months to finalize, because we invited focal point from hospital, focal point from primary health care, and we decided the inclusion and exclusion criteria, who should be attended from hospital, who should be attended from primary health care, because we need people who really representative and have a real experience. And I did like a small presentation, what is the exercise look like a prototype for the record, okay? So after the nomination process, after the nomination process, we conducted 2 separate, because we don't want anyone to affect, or to do like a contamination their thoughts. So that's why we conducted 2 workshops. After that, we send an official letter for the Ministry of Health. This is the result of consensus that we build on the minimum data sets that should be shared between EMR and EHR. And we reached that point and waiting the process of the integration or interoperability.
No, I've asked because like just to give a reality
It's long
check.
term. It's
No, in the sense like, and that's a relatively short time. It's just to give you also a reality check that like these are processes that can take time. They involve a lot of different people.
Bureaucratic.
Exactly. So
bureaucratic,
have when you are defining scope and data elements, it's really like the roles also of people like you here that are really supporting the mapping, to help them to really identify what's really core and what not. So that's a really good example of how procedures can really help you down the line, I think, because you've started all of that. Not to take anything away from implementation, because that's probably one of the hardest points, but to keep the engagement and keep the people in the loop to start getting the right feedback and the right consensus. It's fundamental to like get some buy-in for down the line implementation, I think. So yeah, thank you so much. I think we're gonna take the coffee break now, and when we are back, I will just cover briefly the side of stock data. Okay, thank you. Without your activities, there is no supply of these magical items. So it's a matter of how you are managing those numbers. There are different ways to manage stock data. There are I mean, you see it here, there could be ELMIS, ERP, but nonetheless, these things can also be done partially also within the RHIS, or you can bring in this data coming from other systems that are managing your stock for medical items. And the main reason why we want to start managing well your information on stock and making sure that it's adequate for your data in your health facilities, or in general about your health activities, is because stock data are very prone to distortions. So it could be let's say over reserving some items, or under reserving some items, or having like very little to no idea of what is going on in your activities. And it's very easy to just run out and have like stockouts that last forever. And therefore everything kind of falls into a snowball of effects. You start having a site that has no stock, the people start not showing up, the activity do not continue. And that's when you also have, for example, problem with outbreaks, problem with people not getting vaccinated. It all has an effect. And then you start seeing how everything in the end is linked together. There is nothing in a health information system that has no impact into another activity. So seeing everything together is fundamental. And we were saying, these are common challenges that in the end, we saw that some of them are also common in general health data. But as a matter of fact, the fact that there are siloed instances and siloed kind of type of information that do not connect and do not talk with health data, it's a big problem, as we said before. There is also a problem of what we were saying before, also the idea of feedback, of reactivity time. The fact that a lot is still managed on paper, that means also that when there are actions that need to be taken in order to correct your stock data, your supply data, it takes a long time to, like, for example, do another request of items, or have like an evaluation of what's your actual stock at the end of the day or at the end of the reporting period. And of course, data quality. Data quality is very easy to start counting your products, and then all of a sudden you start seeing that some stuff disappeared. And so the system can also help you to see if there are any kind of discrepancies within your stock, or whether you are doing a correct job in evaluating and kind of forecasting what are you going to need. Within the HIS, we have different products that can be supervised and overviewed for the stock system. So the most basic one is the aggregate. And it can be done directly in health facilities, or it can be, of course, as we were saying the other day, you might not want to do like all at once and full blown in your country, but you might want to take it as steps, and therefore you might want to start at district level. And also it very much depends on your distribution system. In some cases, distribution happens directly at facility level. In some other countries, there might be a central stock that it's a district level or even higher level. And that's when all the items get distributed and dispatched to the different either provinces or facilities. So here we have like two examples of how the data. Here you see the medical items, and here, for example, it's taken from a malaria data set, and it depends on how you design it. And we will see later on for the design for data use, depending on how you design it, what are your needs, and configuring things accordingly. You can have, for example, either have it with a category combination that is like a disaggregation at the end of the day, or having it as completely separate views, because at the end of the day, it might be that the person who counts it and distributes it at the beginning of the day might not be, and usually is not, the same person who counts it at the end of the reporting period. So I really don't care how many we have started, as long as I count at the end of the period how many we have. So it depends very much on the type of implementation that you're doing. You can have also what we call real-time stock tool, which is in the sense of every transaction, every movement of this stock item can be tracked, and can be not really tracked, but in a sense, it can be added and removed from the general stock. And you can also have barcode scanning of these products, so it gets kind of read into the system in an easy way. But this is only available from 240, which is the version of the system. Any Android from 2.8 versions before that, you cannot do them. There is also something very important, and that's very important when it comes to the kind of activities that you're doing in the health facility. You can check your biomedical equipment and see the life cycle. So for example, let's say you have an oxygen concentrator, a ventilator in an operating theater. You might want to check, when did you get this concentrator or this ventilator? How long has it been there? What is the quality of the work that this concentrator is doing? And you can start tracking and following up with this equipment along the time and see what kind of maintenance or kind of servicing you might need to require to this item, and start seeing if you need eventually to request another piece of item. And at the end of the day, you have it by triangulating, for example, how many surgeries you might have in the facilities. And most importantly, it's justified at the end of the day if you're asking for another one. Medical equipment is incredibly expensive. It needs to be justified. Having a good overview of your stock and the life cycle of your items is fundamental in order to ask for new items. And you can have analytics by the organization units, therefore the facilities or any kind of unit of analysis that you might want to have. And then you might have a product catalog. So you, on top of your stock, so you might know how many masks you have and how many masks have you distributed in the hospital and how many you have at the end of the day. You might also want to know what type of masks you have available in your hospital. So there might be a whole variety that you have. It might be that you only have one, but at least you can start checking which ones you have. And if you're running out of one type specifically, you can start requesting the other type of mask. So you can have all the information of the different items, and you can start checking what is available and what not. Of course, as usual, everything that we have comes with a dashboard, a predefined dashboard that can be uptaken or can be left alone because you want to have your own dashboard, which makes total sense as well. But it's just to give you like an idea of the variety of information that you can have through time. You can have, for example, here, it's very much linked about immunizations. So you can track through time how many, for example, alerts for your fridges you might have. So how many times your fridge goes in very high temperature or very low temperature, which can have an impact on your vaccines, of course. And here you can start, for example, mapping things out. It might be like that you want to map which facilities are in stock out within a given period. Or, for example, like here again, it's the same as this, but just displaying where there are high temperature alarms in your areas. It could be that you might have, as we were saying before, it might be that your unit of reference is the province, or it might be that your unit of reference is the facility, is depending on the implementation and the setting. And here you have like the general overview of your stock life. So you have like the opening balance, so how many you have at the beginning, how many you receive at the beginning, how many you distribute throughout the period, and how many you have at the end of the day. The closing balance and the stock on hand are the same concept, but one is manually counted, the other one is automatically calculated. Should be the same. The day that they are not the same is because either you miscounted things or because something happened. And we know that sometimes it happens that people steal stuff. So you see here, these periods, it was all okay. And here we start having some discrepancies. So that's, for example, a good indication of saying, okay, we might want to go and check what is going on with our stock, why there is like a number that is not the same. And what are the outcomes of bringing everything together and having a digital way to have an overview of your stock? So triangulation. I mean, I will try to sell you triangulation in all the possible ways, but because I want you to understand how important this is. Here, for example, on top of the discrepancies that you might have, discrepancies are not just within the medical item itself. So how many I count at the end of the period and how many there are calculated automatically by the system. But also, for example, here we have an example of how many malaria cases were tested with a rapid test and how many rapid tests were issued during that period. And you start checking, for example, here, how is it possible that I've only tested these many people, but I've issued double the amount? What happened then afterwards to that 7,000 tests that I've issued? Did they come back? Did they just disappear and got stolen? So it's just to give you an idea of how important it is to triangulate this kind of information on stock data, which is normally just like considered, okay, how many they're in, they're out. It's just the pharmacist that considers that. No, the pharmacist needs to also check how many you are asking, and you have to check how many the pharmacist or the stock manager is giving out compared to how many I am actually seeing or how many I am asking people to go and visit and treat. So this is just a quick example, but it can be done with a lot of different diseases. It can be done with TB, it can be done with HIV, it can be done with any treatment for any kind of disease. Could be done with family planning. Here we have people for family planning. Can you imagine like how easy it would be for you to see this kind of information? And of course, having a quick overview of your data comes also an idea of you are improving your supply management. And this is what is called the bullwhip effect, because you start with the patient at patient level. And when you start not having a good idea of how many you have, how many they are out, or your demand, And this kind of data, it starts like fluctuating so much that you have a completely distorted version of what is in reality your situation at facility level. So you start like to over ordering, you start to under ordering, and that becomes bigger and bigger through time because you are running low, but at the same time to overcompensate, you start ordering a lot. And you can imagine with the demand and offer that the market is based on, these can have huge impacts on costs and way that you are supplying your items. So just to bring in some ideas of things that you might want to consider throughout the week in order to plan your activities and the way to integrate your data all together, it is very important to consider the fact that stock data brought in and well analyzed has an impact on budget for sure, but we have seen also the added value that in the long run you might have in order to have good data that it's well calculated and well of good quality. You might want to do, of course, a landscape analysis of what is available and what can you do in order to, what we were saying before, overlap and make sure that your plans are working together with the data flow and the workflow of your stock managers, your pharmacists, and any kind of supplier. And of course, I mean, if necessary, implementing the RHIS modules, it's also a big part of the planning that you need to do, because it implies training, it implies implementing, it implies but adapting the data sets and the kind of information that you are taking for the context. So these are the core information and the core messages that I want you to take home. Is the fact that there are a bunch of features and the kind of information that you could extrapolate from the RHIS. And we said it before, we have the aggregate reporting, we have like the rapid one with the mobile, with the scanning, we have the life management, and we have the catalog. And here, like what we can help overcome, so siloed information, the data quality, and the reactivity time if anything happens. And of course, you need to really start planning these kind of things. And we'll see it throughout the week, how important is planning and conducting landscape overview, like we were saying before with our CDC colleague, that they're doing a landscape first for surveillance before they want to act upon it. So yeah, that's just a quick overview. And of course, we have, I am not the lead of the team for supply, of course, and the LMIS team, it's Breno. But nonetheless, if you have any questions, please come to me. And if there are some very technical question, I am happy to even ask him and come back to you, because I mean, I know supply because I've done my own supply in hospital and stuff, but I am not a supply manager or a pharmacist. So I'm very happy though to answer questions if I can. So thank you so much. And yeah, quick question or point.
Yeah, thank you very much for rich information. So just what I noticed, and maybe in the coffee break discussion between the countries, and based on what you presented, still we need to see more. Maybe you convey this message to colleagues specialized in that, about the it's not integration. Let me say that the internal transaction between a tracker and even the program inside the RHIS2 for example, because now we are utilizing the tracker for dispensing drugs in the family health record, or MCH or GP. Once the doctor issued a drug, it should be deducted from somewhere inside the RHIS2 and make automatic stock and count automatically. This is one thing. Another important thing is how making this linkage and notify the doctor that this quantity is empty or not available. Because at that time, the patient will not go for the pharmacy, and we are talking about old age people and the patients. So to avoid some embarrassment and to ask them, go for the pharmacy, and the pharmacy will inform them, okay, we don't have that amount. So if the doctor notified, this is not available drug now. So we will improve the quality of care, and we will improve the experience of care provider while ordering, the system notifying you that this is not available. So the episode of care will be better, and the transaction will be more better. In fact, as a Palestinian team, we are talking about a challenge and experience in that. We have some workaround solution and working on that really. And hopefully it will work, the same scenario, to make integration between the event program, tracker program, and once the doctor make the trigger event is dispensed. If dispensed, so it should be deducted from somewhere, either third-party system and make that deduction and count, or what is called al-jard al-yawmi in Arabic, or to make it internally. Internally, this is the best solution that encourage countries to adopt a tracker more and more as not EMR, because we are not talking about EMR with billing, etc. But at least if we cover this part, we will solve more than 40% of the challenges that make countries reluctant to adopt the tracker in the patient record, because patient record is totally linked with the pharmacy linked with inventory. At the end, it's, there is the admin and finance responsibility on the care provider to make the initial balance, al-arصدة الافتتاحية, and other administrative work. So maybe you can convey, or I can build a business case and share it with you, and we can have a discussion on that.
No, absolutely. And again, I encourage very much this kind of conversation as well in the community of practice.
Yeah.
And mind also your experience and like your workarounds are very important to share in the community of practice. In the community of practice is not necessarily about just sharing successes. It could be just all about, okay, we have this difficulty.
Yeah.
We are trying this. We'll keep you updated. And it could be like, guys, it was a disaster. And it could be, guys, it worked very well. But even if it's a disaster, it's something that you have already given as information to other people, not to go along the road, or to add a value to what you did so that maybe it can benefit you because someone else has found another way. So it just to give you an idea in the sense that think about also sharing this kind of information in the community of practice. And for sure, I will convey that. Partially, I think that again, I'm not an expert, but partially the transaction-based stock management, that one that you were saying that, like that gives you a real time, but indeed what you're meaning is like really the conversation between the pharmacy side of things,
Yeah.
and the patient side of things. And that the only workaround that I can think right now on the spot is just the fact that the doctor has access to the stock at least dashboard to see the items. But I understand that you cannot just scroll down to see all the items, of course, but I will definitely convey that. And I encourage you to also post things in the community of practice, indeed. But yeah, I guess we can move on. And yet again, if you have any question, please feel free to like come to me, and like with Mohammed, like I will report everything back to Breno. Okay, thank you so much. You want me to use mine? Oh, no, I can leave mine, no problem. Ooh. This is how I died. No, I can leave you mine. There's no problem. And then I sit down. I just need like a little bit of water. And it's me again. Okay, I know that you might be bored to hear my voice, but I swear after this brief part, then Ula comes in and it's all much more fun. Quick introduction to the CRVS system, because we know that there is quite a lot of interest in it. And for these, we actually have like made more space for it, just so we are sure to cover a lot of information, but most importantly, for you to have time to actually share with us your concerns, your solutions, and anything else that is related with CRVS. So these a little bit are like the key informations that we are going to cover, and the key messages that we would really like you to take home out of the presentation itself. But of course, we also know that sharing experiences and solutions is key for countries to actually adopt it. What is going on? Is it okay? Okay. Okay, so type of CRVS data. I don't think I have to spend a lot of time here. We all know the type of data that there can be in a CRVS system. It can go from birth to, of course, deaths and stillbirths, of course. It can be marriage. It can be fetal deaths. It can be adoption, and there are like a lot of other type of information depending on country and depending on availability of information. Where is the connection between CRVS and RHIS2? Normally, like a CRVS information, it's coming from another type of system that is at national level, of course. But there are some what we call vital events in the end that come directly from either community or the facility that are of great importance when it comes to feeding into the CRVS system. So it could be very useful to try to integrate the two, and most importantly, try to get all the kind of opportunities to feed this information from the facilities and from the communities into the CRVS, where you see that there are gaps. It might be that you have like some community and like home deliveries, and therefore you might be missing some data on births or deaths of neonatal deaths in general. So trying to find ways and solutions to connect and gather this information directly also from your health services, it could be a very good way of trying to like fill that gap and bridge that gap and find your totals and your good and reliable data. So again, in collaboration with the WHO and UNICEF, we have come up with a program that it's like the vital events, we call it, because as we said, the CRVS is the national system. We have no plan nor desire to take over that side of things. But as I said, this could be a good bridge in case where you see that there are gaps between your health services and your CRVS data, for example. So by taking the data directly from the facilities as well, you can increase the availability of data, of course. You strengthen your population data and in general your statistics, and you expand the coverage of reporting where you are seeing the gaps. The type of events and the flow of information that you have in the vital event package itself, it could be like integrated also in different type of other toolkits that we have. For example, there are like a lot of occasions where you could gather information on vital events. It could be on deaths, for example, and that could come from other packages and other toolkits that we have in the HIS. So for example, TB surveillance, you might have your TB cohort and then all of a sudden someone dies. And it could be that, yes, that case is reported as a death and that goes inside your CRVS without any problem. Or it could be that, especially if it comes from like the outskirts community or some facilities that do not have a lot of access to connectivity and such, it could be that the death remains there floating around and no one really takes care of it. And that person, you add one person, you add another person, you add another person, you add another person. And at the end of the year, it's a lot of people that you are missing and a lot of people that are still contributing to your denominator that don't exist anymore, as a matter of fact. So these are just examples of where also this kind of information coming directly from the facilities could be taken from other type of information. And here I put just a few, like the TB, could be immunization registers, could be surveillance, any kind of surveillance. It could be malaria surveillance. It could be any kind of vaccine preventable surveillance. Let's say it could be measles. It could be any other kind. And of course, it can be integrated also with non-DHIS2. Here I'm talking about DHIS2 based kind of information, but if you have other type of surveillance and such, if you have deaths, it can also be bridged to that, for example. Just to give you an idea of the information flow of what we came up with, again, we are calling them all vital events, but we are mostly focusing because that's the type of information that you're gathering from facilities normally, or in general health structures. You are gathering mostly births, stillbirths, and deaths. And these three types can be registered directly in the DHIS2 system. And you can also bridge it then to feed into your CRVS. Together with that, you of course can have an overview and analyze this data directly in the DHIS2, so with dashboards and such. And of course, you can produce everything else, like it could be line lists, could be dashboards, can be any other kind of analytics. And here I was saying earlier as well, bridging this kind of information with your everyday services is fundamental, where you see your gaps and where the gaps are coming from. So for example, here, it's we have embedded directly some kind of linkage with the immunization registry. Why? Because in a lot of contexts, even if there are like home births and such, immunizations is one of the first entry doors of newborns into the health system. Why? Because I mean, they should be like, for example, I don't know, the first dose of polio is an oral polio dose that should be given at birth. So it's the kind of like entry door that you might want to take advantage of. And so you piggyback on that entrance door and you might want to ask birth details about that baby. Is that baby being registered in the national CRVS? And it could be yes, and therefore you say, okay, all good. Or it could be no, and therefore it could be either that you are taking advantage of the vital events in DHIS2, or that you say, okay, this has been encouraged. You gather the information from the baby and you can alert the CRVS with some automatic alerts. It could be an SMS, it could be an in-system alert, it could be an email to the person who is in charge of this kind of information. And you can alert them that there is a baby called XYZ, son of whoever, that is missing from the CV registration and should be actually in it because it was born on X day. These are just examples of what you can find. This is very tiny, I get it, but you can access our demo, not the Jordan demo that we are using for the specific training today, but for like the general HMIS demo. And you can have a look and play around with the system, of course. It's just to give you an idea of the kind of information is just like the basic information of the baby and parents. And then once it was either born or dead or stillbirth in general, what kind of like information you have on the births. And of course, also the kind of information on deaths, causes and such. And of course, you have like the routine dashboards that give you all the type of information. And added, of course, this kind of information can also come from the CHIS and the toolkit that we saw earlier. There is also a module for vital events and in general CRVS. There is plenty of babies in some areas that do not get access to facilities, and therefore that linkage that we were talking about the health services at facility level, we're not even getting in there, but at least we can get an overview of how many we are missing in the community. So these are screenshots taken from the CRVS module in the community health toolkit. And with this, it was just like a very general overview, but I leave it to Olav to give you also an overview of cause of death and mortality data.
Thank you. So I get the pleasure of talking about the deaths. I'll start with just giving some examples of how mortality data, cause of death data, can be integrated in DHIS2. So I think there are a few examples that we see is being used. So first of all, we have the cause of death reporting. So reporting mortality statistics using the ICD to actually have the cause of death. We've been working with WHO since 2014 on having this support for using DHIS2 to get properly coded cause of death data in DHIS2. Using the ICD framework and the WHO standard cause of death certificates. We also have developed this toolkit around rapid mortality surveillance, which is not meant to give you the cause of death, but to give you an overview of deaths, to be able to look at excess deaths, for example, in a public health emergency. So it's just about capturing deaths in the facilities, in the communities, with only very basic information on the age and the sex of the person who has died, to be able to look at trends and see if there are differences from the typical death statistics. DHIS2 is also used for maternal and perinatal death data, including some countries who do their maternal death auditing through DHIS2. So they have this more comprehensive maternal death audit forms in DHIS2 as well. And of course, within the different health programs, whether it's HIV, it's TB, you typically also include mortality information there as part of the more program-specific information being collected. So starting a bit with the cause of death data specifically. This is slightly old now. It's from it's data up to 2011, but this gives you an idea of countries that are able to produce the cause of death information and report this to WHO. So that's one of the sort of global reporting mechanisms, is that member states of WHO are supposed to report annually cause of death statistics. So you see here, in particular, Africa, of course, Southeast Asia, it's very limited what is produced of cause of death statistics. But even in this region, there are some gaps, as you can see. And of course, if you look at the map of where DHIS2 is used, it's sort of the inverse. So that's sort of a lot of the background to why we started working with the mortality team in WHO on having a module for cause of death reporting in DHIS2. Is because the countries using DHIS2 are the countries who are struggling to report and collect the cause of death information in the first place. So we have this cause of death module in DHIS2. It started out, like I said, 2014. We developed this standard configuration in DHIS2 linked to ICD-10. So we would have the basic structure in DHIS2 in the tracker part of DHIS2, case-based part of DHIS2, with the standard information recommended by WHO for cause of death reporting, and it would let you manually include the coding of the cause of death. So I don't know, for those who are not familiar with this cause of death reporting, it's basically sort of a two-part process, because you first need to collect the information with all, about the person who has died. This was the immediate cause of death caused by this, caused by this. It's sort of a sequence of events leading to the death. And then there are a set of rules for actually coding this information to give you the underlying cause of death, which is what is used for the cause of death's mortality statistics. So it's not enough to just collect the data that the doctor puts on the death certificate. Someone actually needs to know how to do ICD-10 coding and turn that information into an underlying cause of death. So this module in DHIS2 lets you do both. It lets you do the data collection and it lets you do the coding so that you get the correct statistics in the end. So over the last year, what we've done sort of as a follow-up to this initial configuration we had with ICD-10 is to work on a ICD-11. So that's now what WHO is recommending and sort of supporting, is the implementation of ICD-11. And ICD-11 is a bit different sort of from the global side, because there is now actually from WHO this web service for doing ICD-11 searches and coding. So what we have now in DHIS2 is an application that is linked to this WHO ICD-11 web service. So it's using the WHO service for doing searches on the cause of death. And we're working on actually also allowing automated coding of cause of death, which is supported through this WHO web service. So in this cause of death application that is available for DHIS2, it includes the ICD, the cause of death data entry, using the WHO ICD-11 search. It includes dashboards for doing like basic analytics on the mortality data. And it lets you export the mortality data in a format that can be used with this ANACOD tool that WHO is developing for analyzing mortality data. So just to give you sort of a high level sort of flow of the information here, that is supported by this module. So you have a person who dies, a doctor completes the paper form with a medical certificate of the cause of death. So this is sort of a legal document that's paper-based. This certificate is then entered into DHIS2 in this cause of death application. The paper form continues into the civil registration system, who produces the actual death certificate, which is a different document from the one that the doctor fills in. So it's sort of the first one, including the medical information. And then there's a second death certificate that is produced by the civil registry and given to the survivors of the person who have died. So then the medical information is extracted and available in DHIS2 for analysis. This is sort of a more zoomed in view of what is included in this cause of death reporting application. So it's sort of mapped to the different sections in the death certificate, where you have the demographic data, you have the medical data, and you have some additional data around surgeries, on the manner of death, and additional details for maternal deaths. This is then coded to get the underlying cause of death, and you can use it then in ANACOD, in dashboards, etc. This is a just quick look at what this looks like. So this is then what you're seeing here is the WHO ICD-11 web service embedded within the DHIS2 app. So this is DHIS2. And what you see when you get to the search is actually from WHO. the web service. And then you have the included dashboards on the right there. Just to give you an example of how this cause of death information can be linked to the civil registration system. This is an example from Bangladesh. They are using DHIS2 for cause of death reporting. So I won't go through all the details of all the boxes here, but the main point is that they collect the medical certificate of cause of death in DHIS2. This triggers a notification to the civil registration service, and the whole sort of civil registration process around the death, producing the death certificate. Part of that is generating death registration number, which is sort of the official ID from the civil registration side. And this is then pushed back again to DHIS2, where the medical certificate on the cause of death is stored. This is sort of a two-way link between the medical data in DHIS2 and the civil registration system. Just briefly also on the rapid mortality surveillance. Like I mentioned, this is different from the cause of death, because here we're not actually collecting cause of death information. The purpose of this is typically for public health emergencies, where you need to have just sort of a simple way to monitor excess deaths in the country. So this is about collecting very basic information on the age and the sex of the deceased. This is meant to be used both for deaths in the community and in the facility, unlike the cause of death, which is typically only for the institutional deaths. And it's sort of an addition to other types of mortality reporting. And what this lets you do is to look at trends like this. So you see this charts showing the deaths, weekly deaths for the last 5 years. And then you see in 2021, there's suddenly a big spike. So this is sort of lets you monitor whether you have sort of unusual patterns, excess deaths in the country. It does not let you see what is actually the cause of these deaths. So it's sort of a more high-level monitoring of mortality. Final thing that we are including here as an example of including mortality data is around the verbal autopsy. So a verbal autopsy, I don't know if everyone is familiar, but it's basically a system where you have people going out into the communities, interviewing people with this standard data collection tool, asking people about deaths, what were the people who died sick, what were the symptoms, what was their medical history. So you're basically collecting qualitative data about people who have died in the community. And then there are various statistical tools which will take the information that has been collected in the communities and come up with the most likely cause of death for this person. So what we're including in DHIS2 is not this whole sort of work process of collecting the verbal autopsy data or doing the statistical analysis, but including the results, so that you have the results of the mortality data from verbal autopsies available in DHIS2. So I just have very briefly sort of recapping how this mortality data is complementing the other routine health data. So of course you have the mortality analysis sort of in itself, which is useful to complement other data you're collecting around morbidity and on the disease-specific issues. It lets you link to the birth analysis if you're collecting information around deliveries, etc. in DHIS2. It lets you sort of complement the system, health system information around service utilization, etc. It complements the surveillance data, and it lets you do sort of additional equity analysis of the data. So I'll now hand it over to Jean-Paul to give some examples of how the DHIS2 and the CRVS system is linked in Rwanda. Just as a brief introduction, this is about how births in the community is linked through the civil registration into DHIS2 and to the immunization program that is included in DHIS2. So I'll let Jean-Paul give you the sort of a fuller picture of this. And just stop sharing.
Okay, good morning to everyone. I'm going just to share with you a little bit about the implementation of CRVS and also the integration between CRVS and immunization tracker for the Rwanda use case. I'm going also to try to just discuss how we can incorporate this CRVS data within the routine health information system. We have those key points, but maybe I will not be leading everything, but I will just be sharing with you the key points, especially for those who are willing maybe to have this kind of implementation. As a background in Rwanda, we are starting of this academy have been discussing how planning and putting together stakeholders initial when you are starting your planning is very important. The means of health and RHIS Rwanda in collaboration with the ministry in charge of local governments. Okay, now it's fine. Okay, thank you. So as a background, the Ministry of Health, in collaboration with RHIS Rwanda, has collaborated with the ministry in charge of local government and the National Institute of Statistics under Ministry of Local Government. So we have been collaborating to at least improve the performance of CRVS before thinking about the integration of CRVS with immunization tracker. That's a very key part when you are trying to plan ahead what you'll be doing to create a kind of integration of systems. It's good first to plan together, but also trying to prepare what should be the environment before starting thinking about the integration. So we started by improving the existing CRVS, which was under the Ministry of Local Government. And before, the way the civil registration was being done is that in Rwanda, we have the administration hierarchies that we start from the country, provinces, and then after provinces, we have districts. After districts, we have sectors. After sectors, we have cells. After cells, we have villages. So the registration, civil registration was at sector level. So the head of sector was the one in charge of providing those civil registration services. You see how it was very complicated even for the population. You sometimes may find that the head of the sector is on leave for 1 month. So the service for civil registration were not available for that sector because it was offline using those registers. And sometimes you will find that those registers were somehow outdated, service not available 24 hours. So we work together to improve the way system is working, but also in collaboration with the two ministries, they try to improve even that hierarchy and that structure. Then maybe for this, by improving the system, we also enable the CRVS to be able to give those notifications after integration with the immunization tracker. But at this level, I wanted just to share with you how the CRVS was operating. And these two lines is that I wanted to say that the online notification has been enabled for birth and death for the side of the CRVS. I will share with you how now we did the integration between CRVS and the immunization tracker. Then these are the events being in the CRVS, but for us as a health sector, we were interested for birth and death. And then in collaboration with the ministry, as I said, we did those improvements. Of course, as you have said, the first thing to do if you want to have this kind of integrations, especially when it's a closed sector systems integration, you need to have an integrated closed sector framework. Because these two systems are from the different ministries. If you don't have an integrated framework governing the operations, it will be hard for implementation. So you may see some of the examples here, those governing this implementation of CRVS. And then digital certificates now after the improvements can be easily downloaded by either mother, either those who have death cases in their families. You are able now to download those certificates after the improvement of CRVS. But I don't want to talk too much about these two features about death and birth. I will just discuss that after this, just a background about how we did the improvement before the integration. Then I'm saying here that they improve the system on the side of CRVS can now give the notification by, of course, nurse after entering birth and death in the system, the mother or someone who had the representative of the family who had death cases in their family can receive notification after registering death in the CRVS. You may find that before it was manually at the sector level, but now after enabling those notifications and also after working with the local governments, so that at least those two modules, birth and death, currently they are being entered at health center level, at health facility level. The way it is done now, when there is a newborn in the facility, that newborn is registered immediately in maternity service at facility, either health center or hospital, through CRVS by a health care provider. Before, by mandate, it was at sector level. Imagine when you have a new kid in your family, was born at hospital, but you have to move from the hospital going to the sector for registration, for civil registration. But now, after the improvement, we discussed with the local government, now every newborn is registered immediately in the maternity service. Same case for death. if there is someone dying in the inpatient hospitalization service, immediately the clinician should register that death, notify the death in the service in that service. So you see that now we have a real-time notification on the side of CRVS. These are some of the, a summary of steps we that we have taken in collaboration with the two ministries to at least improve this CRVS before the integration with immunization tracker. Then, of course, there were integrated frameworks and also CRVS law and computerization of the CRVS and the rollout. Rollout here means training of public and private health sector staff. Then the last one was the CRVS integration with the immunization registry. Maybe I want to say something about this, about capacity building. You know, you may have systems, but if you don't plan for capacity building, you're likely to fail. For your implementation will fail at 80% because it's a good to have a well-capacitated human resource for you to succeed with these systems. So by experience, we have seen that training these data managers and nurses at facilities was very productive for us to prepare them for the side of CRVS, but also after the integration, we had also to have a kind of refresher how the integration works. Then, this is a summary of how it was. How was it before the integration? The registration was done in paper from a sector, as I said. Then registers sometimes were outdated at sector. You may find that one sector is using X version and another sector is using Y version of the civil register. You will find that even the available variables are not the same. So for someone maybe at country level who wants to compile those reports from CRVS, civil registration, when it's being done manual, it's somehow hard to confirm that data we have at national level is of good quantity, yet they are using different versions of registers, outdated, and also sometimes, not even sometimes, the service were not available 24 hours, I said before. Then they identify, now by using CRVS, each and every newborn has a unique ID. But imagine using registers. There were no unique identifier for each and every newborn. And even before in Rwanda, we used to get the national identity at 16 years old. But now every newborn has what we call national identity number at birth. It means we have national identity at birth by using the CRVS. Then situation after CRVS, in summary now, the CRVS is automated and it has the capacity of being integrated with each and every system because it has an API that's actual, which gave us an opportunity to integrate the CRVS with the immunization tracker because without API, it could be hard. That was about CRVS. Maybe talking about the integration with CRVS and immunization tracker, I will try to summarize some of the key points about how the how the routine health information management is in Rwanda, and maybe what are the key stages we gone through just from the beginning of the implementation of the RHIS up to now. That's the summary of how the country health system is. We started the implementation of the RHIS in 2012 in Rwanda, and currently all health facilities, both public and private facilities, are reporting DHIS. Of course, we have, we started with aggregates, and after now we have tracker. We have different use cases for tracker. I won't go in details, but also we have guiding documents. Before even starting, we collaborated with all stakeholders to have what we call routine health information management SOP, governing who is doing what at which level. We have SOP for hospitals, we have SOPs for health centers and health posts. As you have said, I think the implementation of the HIS in any country is summarized in 3 stages. You start by working on fundamentals like having those guidelines, having that organized and trained human resource, and have that technical people at coordination level. So that's what we did by having these SOPs, by putting together those teams at different levels. I mean, I'm saying as his member who is collaborating with the ministry just to put in place all these things. And then maybe just to say that in 2017, September is where we have collaborated with the ministry through API program to put in place this immunization tracker. Approximately by year, we are registering 370,000 of children in this system. But now this number is increasing after moving from paper-based paper-based to digital system, fully digital system to manage this immunization data. Currently, we are registering more than this, because it came to our intention that probably some of cases were not counted because we are registering now more than this after moving from digital, paper-based to digital ones. And then those are some of the summarized milestones of the HIS implementation in Rwanda. But I think we talked about all those things. Yeah. So let me now take you through the implementation of immunization tracker, and we will discuss about the integration between child-based immunization tracker. So this is the immunization track implementation steps. We did customization. Of course, we started from what was there. The manual work, then we tried to discuss how to improve it before customization, and then we customized the tracker, then we did training, rollout, and then interoperability and data use for action. We would say how now we are at that stage of data use for action now, where we are using different initiatives, including the creation of scorecards, and also we have now currently we have a triangulation work where we are developing a dashboard where we can now put everything, the selected indicators, so that it can be accessible easily for for action. Yes, this is I can say that it's a diagram that shows how now birth registration is being done after the integration. I will also have use this diagram to try to explain how the integration has been done. On the side of CLIVS, we have a nurse, data manager, and also we have head of health center when it is health center, or director of nursing and midwife when it's at hospital level. And then data manager is responsible of notifying, putting those profile for newborn or for a death case in the system. Is the one just doing data entry, data manager. Then after doing data entry, there should be a second level verification and approval, which is to be done by either the head of health center or the director general. After now, let me see whether this can work. Is it working? Okay. So this is where a health provider, it can be a data manager or head of department or a nurse who is on duty, is the one doing notification. And then after doing notification, this is a birth in the maternity. Then after birth, there is a notification. After notification, notifier records birth info in this CRVS. This is the form, and then this is the system. And then after putting in the system, there are different systems interconnected, which are there to host this, to store this data in their database. Is this working? Okay. Then, let me start by this CRVS. This CRVS is connected to what we call National Population Registry. National Population Registry is another instance that has the national ID information for all population. So the CRVS is connected to National Population Registry so that everyone who is registered in CRVS is linked to the national ID number. You see? So anyone, if there is a newborn, is sent to CRVS, and CRVS is now able to provide that unique number, which is called the national identification number. And then, same time, the CRVS birth info is validated. Those registers, certificates, and birth records. This is NIN. This NIN is provided automatically by the CRVS, but the CRVS which is connected to National Population Registry. On the other side, there is that RHIS2. This CRVS also will send information to RHIS2. Also, it will send the information to this National Population Registry. This NIDA means National Identification Agency. So after registering this newborn or a death, the certificate is not provided at health center or health facility. There is another institution which is responsible of providing national official documents. It's called ILEMBO. This is online system. If after being registered, a mother or someone representing the family who have lost their person will go to this ILEMBO to get either birth certificate or death certificate. Yes. Then this is the immunization schedule. We'll not just talk about that. Then, we have those deaths at community and death at facility. So this is the process. Those deaths occurred in the community, they will be registered by the head of the cell and will be sent to the same server as those cases occurred at facility. You can see that I mean with some seconds. Yes. Then the Rwanda Birth Registration Program. These are some of the images from the system. But what I want maybe to highlight before I close is that the integration, during the integration between CRVS and immunization, you can't guarantee the full access to anyone, including those data managers, whoever who is accessing the birth and death module, because this civil registration, civil and vital statistics data, they are confidential. So during the integration, you created a program, intermediate program called birth registration. And CRVS is pushing all newborns through that program, birth registration program. And all those records will be waiting there. And when a new baby come for immunization, they will only go and search from that birth registration program. Those records pushed from the CRVS, they are waiting there. Then a person, a clinical person who is going to vaccinate a child will only use that unique ID generated from the CRVS, and then they will search from that birth registration program. They will get that newborn, and then they will only add the vaccination event. So before, the registration of newborn, when it comes to vaccination, was taking like 10 or between 10 and 5 minutes. But now, because they are only researching and adding the event for vaccination, they are taking like 2 or 1 minute. It depends to how a clinician is familiar with the IT computer. But now it has simplified the things. Same time, simplifying time, but also in terms of human source, I think one person can register 100 of children for one vaccination session. Before, they were not able even to register 20 persons per day. I think the remaining ones are just examples, strength and challenges. Maybe if you allow me, I can just share about challenges for those who are willing to implement this kind of solution. For us, the CRVS is not under the Ministry of Health. The Ministry of Health has only immunization tracker. So you see, sometimes if you want to update something and your systems are integrated, you need to pass and to communicate with that ministry, which is managing CRVS, to update the API. And sometimes it takes time to communicate within the two ministries. But how can we mitigate this one? It's good to at least work together and identify the key data elements you need to put in your API before. Exhaustively, you need to think about those. Otherwise, you will be requesting to add one data element, second data elements, and it takes time to get that confirmation. So there is also high workload at the health center. Even though we are trying to promote tracker, but using tracker requires human resource. So there is a challenge for those facilities which have a high number of children to be vaccinated. Recording them in the HMIS takes time, but due to the fact that it requires some seconds to update one records, also it's a good opportunity. But high workload is an issue you have to expect and think how you will mitigate it. Yes, thank you very much. Yes, very sorry, I tried to summarize, but I had a lot to share. Thank you.
Yeah, please, if there are any questions for Vito, Olav, or Jean-Paul.
Thank you very much. Actually, I have 3 questions for you and 1 for Olav. First of all, what do you mean by sector office and cell office? What difference between them that you use for reporting? Okay. What the sector office and cell office do you use the Rwanda to report? The second one, how you deal with the home deaths? in small country like Palestine, we have about 45% of deaths happened outside the facilities. And you didn't explain something about the underlying cause of death, who report and who decide and when, at what stage or process. Thank you.
Thank you very much. Starting from what do we call cells and sector? I said that administration hierarchy in Rwanda, we start to have a country, and then under the country you have province, under province you have districts, after districts we have sectors, after sectors we have cells, after cells we have villages. So the civil registration was being done at sector level. That's what I meant. Is that clear for that? Yeah, it's an organization, it's a level one of the hierarchy. So it's an entity. A sector has more cells. Under sector, we have more main cells. Under cells, we have main villages. So at sector level, at sector office is where the civil registration was being done.
Yani from village to cell, they report paper, yeah?
No, that time, when you have a newborn in your family at a given facility, after being discharged from the facility, you are supposed to go to the sector for registering your kids in civil registry.
You didn't have home deliveries in Rwanda?
That for the birth at facility, and then for home deliveries, by law you need to register your kid within 30 days.
Yeah.
So if you have home delivery, you are also supposed to go to the sector within those 30 days. That was before, but also I want to highlight that now in Rwanda, 99% of deliveries are at facility. The home deliveries are below 1%. Yeah, because the strategy is that we have a community health worker at each village, and we have 4 community health workers at the village, and among those 4, there is one in charge of maternal health, and he is supposed to know each and every pregnant woman and gestation age. So she is the one making sure that he is going to take the pregnant women to the facility for delivery. Actually, most of pregnant women, when they are coming to the facility, they are coming with their supervising community health workers. So those community health workers are contributing to prevent those home deliveries. So now after integrating with the CRVS and immunization tracker, not even integrating, after improving the CRVS, how now it's being done. When there is a death case or a birth, a newborn, it is notified immediately in the delivery room. And then you are done. You will just go to Ilembo to get the birth certificate or death certificate. This is now done. When there is a death or birth occurred in the facility, you are immediately registered. But we do have those few cases who are delivering in their homes. Outside. But also we do have those death cases at home.
For deaths, you used ICD-10?
Yes.
Yeah.
We for death, we have this improved the certificate of death, which is for ICD-10. Then medical doctors have been trained for ICD-10. Actually, now we have ICD-11. They are trained. They know how to name, previously someone has said about that. Without using those ICD-10, you may find that someone is there. We have 5 cases of death with a similar cause of death, but doctors have named differently. So now using ICD-10, at least a doctor is able to name correctly the cause of death. Then after filling that cause of death, that certificate is passed to data manager office
Mhm.
for him to enter the records in the cause of death.
Mhm.
And by using codes, they will be able to identify what is the direct cause of death,
Underlying
what is the underlying cause of death.
Yeah.
So those deaths occurred at the facility, it's easy to register, but for those cases in community, it's the responsibility of the head of the cell.
Mhm.
Because in Rwanda, you can't, if you have a newborn, the community health workers will alert the head of the cell that there is a newborn in my village. But also if there is a death, you can't have those burial services without having the certificate from the cell village. And having the certificate from the cell village, you have to be registered in the TRVS. That's how it's being done.
Thank you.
And what was the other question?
No, you covered the three questions, but I have one. I'm not sure how you are working in Rwanda, but what Olaf presented that when the Oslo University developed the platform for cause of death, they used facility-based. We already developed in 2019 the platform in Palestine. We used the locality based, not the facility, because we have 45% of the deaths outside facility. I think for the countries that they have the same story like Palestine, it's better for them to use the locality based, not facility based, when they consider the DHIS2 for cause of death.
Maybe Olaf, I don't know whether we say something on that.
Yeah, no, I think that's a good point. So the focus on this cause of death collaboration with WHO so far has been on the institutional deaths. So we're not really to the point where we started discussing how to do the rest. So it's sort of limited to those deaths that actually get the medical certificate on the cause of death filled out by the doctor in the first place. And then, of course, the verbal autopsy part is sort of one way to address this gap of all those who die outside of the health facilities. But then that's also slightly, I'm not sure if sensitive is a right word, but sort of how much emphasis to put on the verbal autopsy, I think is also something that is being discussed. I don't know if you have something to add there on as well from the WHO.
Yeah, it's so just to back up on some of Olaf and the WHO side. So in the past, it has always been the medical certification for the cause of death has been the key focus for WHO, and trying to build the capacity for country to do the right diagnosis for cause of death and standardize it through the ICD-10 and now ICD-11. But especially with the COVID-19, the importance of getting all cause of death through the mortality surveillance has been emphasized. And we have developed the tool for the mortality surveillance, and that's supposed to be introduced at the community where there is not enough capacity to do a proper medical certified cause of death. But at least we get on the death, and then so we are working together with Oslo, but also with different partners, trying to bring all of that into one we call end-to-end solution, where we would be able to collect the cause of death, so with practically the total number of deaths at the community, and then combine that with the institutional based mortality with proper cause of death, and then trying to have a better understanding of the excess mortality, but also of the full picture of the cause of death. Work together with other sectors for the vital registries, just to understand if there's always a lag between, or the time gap between what is reported to the vital strategy and what we can pick up, and harmonize this kind of data flow. And the vital strategy comes in as one of the sort of more quality aspects into the cause of death and better understanding the cause of death for burden of diseases and other. And this is also now coming into picture, but how we do that is very much of country per country specific case, and who is supporting the country in the partner. So far, those who are under the data for health Bloomberg supports, then there will be some partners there trying to implement it in the country. But I think this is, again, we have to treat it by per countries and see how the country regulation and policy on CRVS. But, you know, we understand the advantage and the benefits of having all of that into one system. And this might be one of the way to sensitize and to bring the awareness and bring the support in having different means and different data sources for collecting mortality data, but to bring it all together and its purpose. So I think this is something any countries are interested. We are very happy to discuss further and see how we can support.
Yeah.
And we have this kind of end-to-end solution, and we've been working together, and hopefully it will be, I think it has been built in the HIS2 now. So we have a tool ready. It is lots of it is legislation, data governance, and coordination to have it done.
Maybe just one comment. I just want to highlight that when there is a case, birth or death in the community, for cells, for the head of the cells, for them, they do notification. But when it comes to the certificate of death or the cause of death, there is something called verbal autopsy. So the hospital or the hospital in charge of that catchment where that case happened would send clinicians to go to the specific family to do that verbal autopsy, and they will come back with information for them to complete the verbal autopsy, I mean the cause of death module. So for them, the head of the cell is not clinician. For them is notification, but through that verbal autopsy, we are able to identify what's the cause of death from the community and bring the information at facility level for updating the cause of death module. Yeah. Any question? Thank you very much.
Oh, it's okay, we're recording. Okay, thank you, everyone. So we'll take our lunch break right now. It's in the same location as yesterday, and we'll come back in an hour's time, okay? Thank you.
How we can incorporate population data and other non-routine data into DHIS2. So this is just a short 15-minute presentation, but it's a quite important topic because basically all your other analytics more or less relies on getting this right. So much of the analysis we're doing is based on having good denominator data. So this is sort of a small but critical element. So the goal is to talk a bit about why this non-routine data is important to include in DHIS2. A bit about how we can work with the non-routine and data together, and how this can be set up in the best way in DHIS2. So just a quick background first. Why is it useful to have the non-routine data? I think Victoria already talked a bit about data triangulation this morning. So looking at multiple data sources. One way of doing that is bringing in the non-routine data sources and looking at it together with the routine data for triangulation. It could be looking at your immunization coverage from the routine data with the immunization coverage from household surveys, for example. And also you can bring in non-survey data, like data from campaigns, which is typically handled outside of the routine system, but you can bring in the results to be able to do analytics. So we'll see an example of a vaccination campaign dashboard later. So if we think of the typical health indicator that is monitored routinely, I would say most of them are based on having some sort of population, often population, but at least having some sort of denominator that is not collected routinely. So if we think, for example, of immunization, we have the coverage indicators using the population data as denominator. We have the maternal health, looking at antenatal care coverage, using the expected pregnancies as the denominator. For malaria, you might be looking at the annual blood examination rate with the population at risk as your denominator. So there are all these core indicators from different health areas that rely on having good non-routine denominator data available. So just an example on the right here, we have BCG coverage indicator. Your service data, it could be coming from a case-based system. It could be coming from your monthly immunization reports. But in any case, you need to have the under one population as available in DHIS2 to be able to produce the coverage indicators. If you look at this, I don't know if any of you have seen this global reference list of health indicators from WHO. So what the WHO and partners has sort of identified as the 100 most important health indicators, including the SDGs that are health related. Very small subset of those are actually from routine systems. A lot of it is only available through service. So if you want to use DHIS2 as a analysis platform where you have all your key health indicators, you will need to bring in not only the denominator data, but also survey results. Another example here, if you think of data quality, one way to assess your data quality is to do triangulation. So in this case, this is from the WHO data quality review framework, which includes an element where you look at your coverage indicators based on routine reporting versus coverage indicators from household surveys. So let's look a bit on how this could be done in DHIS. So what we generally recommend when it comes to population data and denominators is that in DHIS2 you have one data set which is used across all the health services. So getting all the health programs departments to agree on one set of core population indicators. This is often like the core indicator population data set is often based on census data that is then used with some projections to get estimates between the censuses. So having that as a common data set in DHIS2 is sort of the recommended approach. Then there are some specificities here. For example, if you're doing if you have a new census, there are new projections. You need to make sure you not only include the future projections, but also ideally update historical data with the updated projections so that you get you're able to do proper year-over-year trends of the population-based indicators. in addition to having this sort of core population data set, it is possible and useful in many cases to include sort of alternative denominators. So in some cases, different health programs will have will want to have sort of special in population denominators. It could be, for example, that you would want population estimates based on service data. That's sort of one approach. It's important then to differentiate these sort of other population estimates from your core population data set. In countries where you have strong civil registration systems, perhaps you would want to have the census population estimates, but you would also, for example, want to bring in your numbers from birth registrations. So you have an additional denominator available for live births from the CRVS. So I think the third thing here, which I'll go a bit more into detail on, is pulling in population estimates from other sources. So that's something, there's been a lot of work in the RHIS platform itself over the last few years on making it easier to use alternative population sources and bringing those directly into the RHIS2 for analysis. So these are just a few examples from the RHIS2 map application, which I think is part of the RHIS2 that is often very sort of underutilized, underestimated. But the map application of the RHIS2 is actually become a very powerful GIS tool. And among the relatively new features here now is that you're able to pull in from different global population estimate sources into the maps application, alternative population estimates. So for example, there is this initiative called Grid 3. There is the World Population Project that provides population estimates. You can visualize those in the maps application of the RHIS2. And with the latest version of the RHIS2, you can also actually import those population estimates as a data set in the RHIS2 and use them in indicator calculations, etc. Another relatively new feature is that you can actually bring in from Google Earth Engine structures from satellite maps. So the individual houses from satellite images and display them on within the maps application of the RHIS2. So if you're sort of going in depth on trying to look at your indicators sort of geographically, you can zoom in and look at where you actually have the clusters of households related to the health facilities and the indicator data for those health facilities. There is also an application that lets you calculate catchment areas for health facilities. So using this called the Crosscut is a company that has developed this, but it's becoming available also within the RHIS2. So based on geographical data about the health facilities, location of the health facilities, it's looking at things like travel time for the population to get to the nearest health facility, the terrain, etc. So using the geographical features to actually draw up catchment boundaries around the health facilities. So you start with the location of the health facility. The system will look at the geography, the roads and everything, and it will figure out the sort of the boundaries, what locations, what households will have this health facility as their nearest health facility. I think we've already talked a bit about this org unit profile. There's also a new feature within the Maps application that lets you visualize information about the health facilities. There are also some new features. New features coming in the, I think, in the next 1 or 2 releases. So one is to be able to identify settlements, so not just the structures, but sort of clusters of structures. And look again at the travel time from these settlements to the various health facilities that you have geographical coordinates for. Looking at the travel time based on the facility catchments. So from a health facility, what is the travel time in different directions? Enabling you to visualize that. And the last one is allowing printing of maps from the Maps application to use, for example, if you're doing campaign planning and you prefer to have paper tools for doing that. So that was a bit around the population and the different ways that is integrated in Maps in particular. I think, as I mentioned initially, big part of sort of the core health indicators is based on survey data, household surveys. And the aggregate model of DHIS2 is quite well suitable for storing that information. So not actually doing the household surveys with DHIS2, but once you have the results, to bring those into DHIS2, enabling you to do analysis, to do triangulation with the routine data, etc. There are often some things when you're actually going into DHIS2 to set this up, some things that you need to keep in mind. One thing is, of course, that the survey data is perhaps available with every 3 years, every 5 years. So the way you set up the data elements, the indicators, needs to take into account for what periods you want this survey data to be available for when you're doing analysis in DHIS2. Another issue is that the household surveys sometimes are not done and aggregated based on the same administrative hierarchy as you would have in DHIS2. Because of the way the households are sampled, etc., you might not have the regions, the districts that you have in DHIS2 for the survey results. That was the population survey. Then I think a third sort of major area where it's useful to bring in non-routine data into DHIS2 is around campaigns and other sort of non-routine interventions like active case detection for malaria, etc. So if you use the campaigns as an example, you can bring in your campaign data if you have immunization campaigns to address immunization gaps. You can bring it into DHIS2, and then you can do triangulation with campaign data and the routine data on immunization, for example. So there are some sort of best practices you need to keep in mind. For example, not adding up the routine and the campaigns, because then you sort of lose track of, you're not able to follow the trends in the routine immunization, etc., if you just lump them together. So keeping the underlying data separate, but then you can use indicators within DHIS2 for the cases where you want to actually look at the combination of the campaign and the routine data. Similarly, if you're collecting routinely malaria case data, and you're also doing active case surveillance for malaria, keeping those separate so you're not sort of conflating data collecting through different means. So I think at this point, I will ask Vito to just give a quick example of what a campaign type dashboard can look like in DHIS.
Yes, super quickly. This is actually a real example. These are retrospective data, but nonetheless, a real example from a meningitis campaign that happened in Niger. And this is what they ended up visualizing for, like, because they started bringing in all the retrospective data for the all the campaigns they have done it. For those who are not aware, Niger belongs to one of those countries, is one of those countries that belong to the, what is called the meningitis belt. So they have like every year, they have recurrent outbreaks of meningitis, and therefore meningitis campaigns are pretty much almost routine there, but nonetheless, they are campaigns that can happen either at national level or at local level. This one was a national campaign, and we just wanted to highlight how important it is to bring all these kind of sources of information together. Why? Because you can start triangulating the campaign data and the campaign results together with, you might know, for example, that when you have either immunization campaigns, or it could be a BetNet campaign, or it could be a mass drug distribution campaign. You might want to do surveys for coverage afterwards. And when you do coverage for coverage, you can start triangulating those results with your routine coverage as well, or update your coverage until that was there until that moment with the new coverage that you have achieved during the campaign. And we just wanted to like show you, for example, the overall coverage you see here. Normally, when you think of a coverage, it shouldn't go above the 100%, but here we went 105%. So why that could be? It's because of the denominators at the end of the day. And once you start checking the curves of distribution, here we have, for example, the doses by the type of site, by the age groups and such. Here you have a map of the different coverages by the different districts as well. And you see that the majority of the districts in the end are in orange, which means that they have a coverage that is above 100%. And that can happen with, like, here is an example of immunization campaign, but it can happen with any type of campaign. And you see, for example, here, once you start disaggregating by age, you start seeing, for example, that the main problem here was that the age group between 1 and 5 years, they were more than they were expected. And these are the kind of information that when you bring in your routine information system and in general, you start triangulating with your routine data, this is the most important kind of information that you can triangulate. Why? Because now you have found out that in these areas where the coverage is more than 100%, chances are your children below 5, that you have quite a lot of children that were not registered in the national system, for example. So this was just like a quick example, just to give you an idea of what kind of information you can triangulate, but most importantly, what kind of information you can extrapolate when you start triangulating, when you start adding things together. So I'll give it back to you.
Thank you, Vito. So that was actually the end of this short session. We are already a bit over time, but if there are some burning questions specifically to the issue of population and non-routine data in DHIS2, yep.
Thank you for the presentation, Olaf. Just a question from previous session for the death. If the case registered as a death, and we have one unified instance for all cases on unique identifier, so can we block the TEI from the system to notify the user that this case or this patient is died, just to avoid the wrong data entry while they're entering? So we need to keep it inside the system, yeah, but notify if it happens by.
It's maybe something.
Can you do it in a program rule?
Yeah, that's why I can't answer from the top of my head whether. I'm not sure actually. So that's something we can look at. Because I agree that's an important point, because you need to keep the enrollment and all the data there, but you don't want additional data.
Okay, so we'll test it. The program.
It's not related to your session, but in general, will be in this workshop a walkthrough, actual walkthrough through the system. Is not just only presentation or actual exercises where we enter data and use the system. Because information like this is in the presentation, though it's comprehensive, but unless we practice it or see it, it's not going to stick. That's it.
Yeah, so we had a very brief session yesterday. I think I'm looking at you, Ajit. We have an exercise later today, but I'm not 100% sure how much that will be in DHIS. I think we'll be using the DHIS dashboards at least to do some analysis there. Yeah, but in general, this is not a sort of DHIS 2 training, so it's limited what we'll actually be doing in DHIS 2. If there are no final questions, I guess I'll leave the floor to Vito again. Okay.
Sorry, just a little announcement. So for those of you who did not get the opportunity yesterday to be on the group picture, just note that we'll have one at the tea break at 3 p.m. So please stay here. So we'll take the picture for all of you, those who did not, who were not on the group picture yesterday. But before doing so, I will need you then, if you are willing to take the picture, to sign and complete a little form, which is basically a consent form, to allow us to use your picture for campaigns and promotions of academies. So if you could raise your hands and I will give you the form. I think there were other participants, not only you from Zimbabwe. If you could just raise your hands. No?
Anyone else who has not signed up? Don't be shy. Alice will not hurt you if you have not signed the form before. Okay, you can go in private if you're shy. Okay, I will try to break the record for the shortest presentation of the week. But we think that it's important to also give you an idea of other type of information that you can add on top of your health facility and community and stock and population. And there are also other data that are very much linked with the facilities. And we have started working together with the Global Fund and the WHO on these quite a while ago, but it's something that it's a very extensive type of work, and it has a lot of information. So it has been a long process of try to reduce to the minimum the core type of indications that you want to collect for evaluating your facilities. So and instead of calling it, it's based very much on the harmonized health facility. Oh, the A stands for assessment. Thank you. It's because we were calling it now health facility attributes. And what are these attributes? If you are acquainted with the way that DHIS works, attributes are normally type of informations that are not very variable for the person. So for example, the name of the person is an attribute. The date of birth of a person is an attribute. So we are calling it health facility attributes because per se, these kind of these kind of, but in the end, they are data elements, but they are variables nonetheless, are not changing for the facility itself. What you are trying to evaluate for that facility remains for that facility. So, and also why they are semi-permanent and not exactly the normal way that we do attributes, because you can decide a little bit also the frequency of collection. This is supposed to be a self-administered way of evaluating the readiness and accessibility of the services and the equipment and all that comes with it. And you can have it, for example, every 6 months. You can have it once a year, every quarter. Is very much dependent on the type of ruling and the type of implementations that you have locally. What can you achieve out of that? You can have, for example, an overview of the availability and whether you're providing different type of healthcare services, the equipment that you have available for those health services. So for example, you have malaria as a health service, and you can start entering data on whether you have like readily available laboratory services for malaria, or for example, quick tests for malaria, if you're available, for example, maternal care for malaria, or if you only have a quick outpatient and there is no ability to take inpatients for malaria, for example. You have a little bit an overview of the staff that you have at facility level. So for example, the number of doctors that you might have, the number of specialists that you might have, the number of nurses, etc. You can have an overview of the infrastructure. So comes from either if you have connectivity, if you have electricity, as well as wash information. Therefore, if you have like access to clean water, if you have access to toilets or latrines or whatever comes with it. And of course, the preparedness of your health system in case of emergency. As I said, it is very much based on the HHFA, and that gives you really like the full picture of all the assessment that is needed for evaluating the health facilities. This is a subset. So what it means is what? It can be linked in case the HHFA is already uptaken routinely. It can be linked to it. So at least the core information that you are using to evaluate your accessibility and your readiness of the facilities, you can still link it and still maintain that type of information linked to the facility. So do you remember yesterday that we were also having an overview of what you can do at facility level, that you can map it out, you can see the catchment areas, you can see the population distribution, you can see like sex disaggregation and things like that. You could also start having this kind of information at facility level in order to see have a clear overview of what you can offer and what is the status of that facility per se. I'm too tall for this. So, as we said it, the main modules that are part of these are based on the HIRAMs and the HHFA, of course. So you have service availability, service readiness, and the government and management, which are like the three main core way of evaluating your facilities. Then within those three main modules, let's call it, you talk about staff, you talk about service provision, and then what I was saying earlier, infrastructure, power, IPC, that is prevention, controller, and hygiene in general. So like all your wash activities. And then you have also government and management. So a little bit on the idea of whether you have like a government body within your facility, if there is any kind of management structure in your facility, going also like, for example, if you have a bank account for your facility. And this is all very flexible in the sense like we digitize the questionnaire that it can be for self-reporting, but you can add and remove this kind of information depending on what kind of, resources you might have, but also what kind of information you can extrapolate at facility level at the end of the day. So how to adopt it? I mean, in the end, it's not that different from other modules to be fair. So you need to, of course, review what you have at facility level, what kind of services, because of course, what is being put out from our side, it's a general thing. So you might not have malaria services, you might not have family planning, you might not have HIV services. It's very much dependent on what you have locally. So you need to start reviewing the questionnaire and adapt it, which means reducing or expanding depending on the content. You might determine the frequency that you want to use for this kind of evaluation. It can be, as I said, quarterly, 6 monthly, once a year, once every 5 years. It's very much dependent on you and what the management team wants to do with it. You need to check the level of data collection. And of course, that is also very dependent on whether the health facility has internet or not. You need to start using a little bit and start deciding what is your baseline of source of information. So maybe is the WHO standardized way of collecting data, or you're just going directly with the DHIS side of things, and or you can use the WHO way of doing and then importing some of those answers in the DHIS modules. And then you start collecting the data. And you need to make sure that this data is available across all the different programs, because of course it's a self-administered questionnaire. So you need to make sure that all the relevant sources will have access to this type of questionnaire. And of course, the big part of this is actually training, because especially when you don't have an integrated system where you can retrieve all this information easily, getting information on WASH, on services, on staff, on budget and things like that, it can be very time consuming, you can imagine. So also having a good system behind it and train the people who will have to do this type of collection, it's super important. And we said it's very flexible, it's very adaptable to the different contexts, of course. There is a dashboard that is available, like all the toolkits that we put out. And there are plenty of implementation guides that either comes with the HHFA or the HIRAMs, and of course, also with the module itself. So how do they all relate together? I mean, in the end, the whole point of all these type of evaluations is to capture a little bit the key information, to have it a little bit more frequently, because chances are most of the times that these type of facility assessments are done, it's either because you have received big investments from donors, or they are rarely done on routine. But we have seen examples that is not necessarily true. We were talking with our colleagues from Tunisia, and they have been doing great at really maintaining a routine assessment up to date based on goals, and where they really go back and check that everything has been done. So well done to you. And this is just another resource that can be added on top of it. And what is the added value of having all of these? Because of course, it's very easy to say, okay, this is just an extra level of data and it's incredibly painful to do. It is true, but so you can better plan for resource allocation. Why? Because on top of your facility information for services, you have your logistics, you have everything. And then on top of these, you start adding the key information on the readiness and the availability of your services. You can start identifying the bottlenecks where these resource allocation and where these services are finding a gap, and therefore you can start acting upon it. And then you can start preparing, responding to emergencies. Why? Because you have identified where probably your bottlenecks are intervening and where they are playing a role into the access to those services. And because you have learned how these facilities are profiling, and you can check afterwards what you can improve out of that facility, be it on resources, be it on staff, be it on service provision. And you can start therefore evaluate already in case of emergency, what would be the best approach and what, for example, what are the key facilities that can respond to certain emergencies. Then here you have like quite a few examples. Some are taken from this module, some are taken also from the, for example, the rehab module, and another one that will come out soon about sensory functions, so vision, hearing, and such, which can be of interest because it all falls into the NCT side of things. And you see there are mappings. You can like have like the profile of the health of the workforce in health. You can start having it either in graphs or in maps to see the density per population. And for example, you can also see like the number of specialists, how many beds you have, how many IPD like actual bed you have against how many you are supposed to have, because we all know that sometimes the actual beds are normally more than the beds that you are supposed to have. So it can also be the fact that you might want to start plotting how this is going. And of course, you can also start checking, for example, caseload per staff, because you start triangulating also the kind of information from the service together with how many stuff you have out of that. So you might have, I don't know, in this case was eye care, because we are taking the graph from another toolkit, but it could be also, I don't know, you have like 2 surgeons, but you are having 200 surgeries. So you can start evaluating whether the caseload per surgeon is actually maybe a bit too much or is not enough. And therefore we need to start taking maybe like more people in, and we can become like, I don't know, a more referential way of accepting patients. So overall, like the whole point here is the fact that, yes, there are like extra information that can be added on top of things in the profile of the facilities, but this can be an added value and not just a more painful way of collecting extra information, because once you start triangulating all this information together with your facility data and your health data, you can start checking really where the gaps are in your facility and when you need to start investing. And also start checking whether the investments that have already happened are actually having an effect in the availability and the accessibility and the readiness of the services that you are providing. So that was really like very short, also because it's something that we are still developing and working on and ready to pilot pretty soon. And yeah, so we just wanted to share with you because it's incredibly important in an integrated system. And I don't know if you have like any additional comment towards that. Yes, Anne, yeah.
So just an additional some of the background for this work. I think it came from 2 key areas. Number one was some of the initiative from countries, and it's a lot linked to maybe some of the country here have done it, which is called the result-based financing, where they actually have to report the progress to the donors, and then from there they will be able to get funding for the services. And with that, it's also including the funding for a lot of it is the readiness of the service, to making sure that we have enough equipments and essential medicines and commodities. So this has been implemented in several countries through the RHIS2 network as part of, number one, readiness and for the country. Number 2 is also to showcase of the HMIS, the health management information for the planning. Number 3, it is also help to improve the quality of the services. And then with COVID and WHO also presenting or introducing this toolkit called the Pulse Survey, where every quarter we send a questionnaire to countries to trying to see, what are the missing elements to maintain essential health services of primary health care level and other health facilities. So this put together, and we trying to see how we can best to bring this as part of the health management information system and as part of the integrated cross-cutting health service, where we combine the volume of patients, where they are from, what service they want versus what the facility are supposed to provide, and if they are ready to provide the service in terms of infrastructure, in terms of commodity and logistics, in terms of human resource, in terms of the time, and also just across triangulation of the data. So we're also trying to bring it in as either quarterly or biannual, and combine that with the supportive supervisions. And the key important thing here is that this should be done as a part of the coordinated efforts across all different programs or different components of the health services. So, for example, if you have a family planning and maternal and child health supportive supervision, you should go and look at that. And then, malaria or TB or HIV have a similar, they can go and look at that. So they have one standard templates that everybody can look at, and then make sure that the health facility managers are aware of what they have, and then maintain the services. So, and this is also developed based on I think here many will be familiar to the HARIM, but then also the HERAM, and then also we have what we call the health facility, the harmonized health facility assessment, where it's evolved and is extended from the former SARA survey, which we also trying to encourage country to do it once in a while for the assessment of the readiness and availability of service in the country. And that should form as a baseline for the monitoring of these health facility attributes. So if you have further questions, Victoria and I are happy to respond. Thanks.
Any questions? Post lunch? Okay, the coma post lunch, no worries. If you have any questions afterwards, like when you wake up a little bit better, you know where we are sitting, huh?
Okay, everyone. So I'm going to switch gears a little bit right now. We have spent most of the morning talking about different data types that are part of an RHIS. And what I'm going to talk about is a little bit more kind of thinking through all these data types and how we can look at data quality of these various integrated components. So I'm just going to start with some baseline principles here, just to make sure we're all on the same page. And I'm going to describe some basic principles of data quality. I'll then identify some specific tools in DHIS too. I'll describe some of them. I'll also demonstrate some of them as well, so you can get a better picture of what they actually look like. And I'll also describe some of the principles of integrating data quality within a health information system. All right, so a number of the data quality components that we are reviewing or that we will be discussing are based on these basic guidelines that WHO has developed, this data quality assurance toolkit. I've posted the link in the presentation. There are 3 different modules that are available. Many of the principles that we pull from, a lot of the features that we demonstrate, a lot of the items that we will discuss are based on these 3 items. Okay. So if anyone is familiar with these, then some of this might be kind of linking to this guidance. So when we're looking at data quality, there is different frequencies that we can assess and think of, right? And you guys probably have some idea of this in your own context or in your own setting. How often do you actually look at the data? Now, where we typically run into problems is reviewing that data routinely, right? Maybe you, in many contexts that we typically work with, they will look at the data towards the end of the year. They'll run an annual analysis. At that point, they will review the data and provide feedback on its quality. Another area where we typically have many challenges is sending that feedback down to the source of the data itself. Yesterday, during the exercise, you guys learned a lot about how the source data can be kind of incorrect and based on how people are tallying things, for example. And often the discussion around this is at maybe central levels or provincial levels, and there's not enough kind of information fed back to those lower levels of the system that are responsible for reporting that data. So one of our jobs is actually to take all this different data that we're collecting and kind of figure out innovative ways to present this back to individuals who can then interpret this, try to make it a bit easier, basically, so we can spread out the amount of burden regarding this review of data, right? It shouldn't all be at the central level, because that makes it difficult to actually determine whether or not, your statistics are correct. So there's, I've separated this out into a couple different periods. We have weekly or monthly review, which is hopefully being conducted at lower levels of the system, or the idea would be generally to try to implement procedures that allow people at lower levels of the system to conduct that analysis routinely. You then have annual reviews. These can be maybe a bit more time consuming, right? Might involve some other experts. You might bring in an outside expert, an external advisor, or might involve a central team of experts who are very well versed in these data quality principles. And then you might have these periodic reviews. These are often program specific. So for example, you might have a malaria review. Someone might come in from outside, or you might have your own internal team, and they will conduct a thorough review, not just of the data. They will conduct also service delivery reviews as well. But there will be some focus, of course, on the quality of that information for that program. So we're going to try and break this down a little bit in terms of how we can feed into this process a little bit more routinely. So within those kind of different types of reviews, we have different types of data quality review that we can perform. So this includes verification surveys. This means that we're actually traveling down to the location, a facility or a district, and actually verifying their data. So there is some travel required, but speaking with some of you today and yesterday, I understand that some of you are already doing this. We're actually going physically to verify the data at a specific site or a district or another location, a physical location, right? You can also do this kind of, we call it a desk review, but really whichever level you're at, provincial, national, district, where you're kind of performing a kind of joint review of data without having to physically go to a site and review it. So this would mean that the data is then reported to you, you have it on hand, and you're able to actually review that data through some processes that you've defined. We then also have some built-in tools. I put validation rules as an example, but we have some tools within DHIS2 that will allow you to review that data at the point of entry or later on at another time. So there are also some tools to facilitate this process within the application itself. So I'm just going to discuss a couple of different metrics that we often use for data quality. There might be additional ones. I'm not saying what I'm presenting are the only ones, but these are ones we might typically assess. And in particular, there are many tools in DHIS2 to support the review of these specific metrics. So as an example here on screen, I apologize, the screenshot's a little difficult to see. I will do a bit of a demo so you can see some of these as well. The first metric is data set completeness and timeliness. I say data set, but this is like just your form, your tally sheet from yesterday. It's essentially the same concept, okay? And we apply this concept typically to aggregate data for the most part, right? So you might have case-based data as well. It's a little less intuitive to apply the concept of completeness and timeliness when you're reporting every individual case. So there are ways to do that, but it's more difficult to aggregate those measures, okay? So what we've noticed is that in particular, this measure, it's okay in many places. It's improving in particular, a lot more countries, especially as they implement electronic tools, or if they had other tools, if it wasn't DHIS2, regardless of what they're using. Sometimes this is okay. But what we want to emphasize is this is not the only measure of quality, right? A lot of people kind of have that idea, while the data is being reported on time, I can see the data, therefore my data processes are okay. So another metric that we often use is consistency over time. This in particular is a very good one to use because it's very, at different levels can be very easy for people to interpret. You don't necessarily need a lot of training necessarily to have people identify values that are inconsistent with previous ones. There's often big spikes or small spikes where the data is missing, and this is very easy to spot, right? We also have things like outlier analyses. This may be referring to either internal consistency, where you might be comparing two variables you're collecting within your system, or external consistency, where Olav mentioned this earlier a little bit, right? Where you're comparing a variable you're collecting with maybe some outside source from another system, or maybe a survey or a census or something like this to determine if these are compatible with each other. Right there. And then another important item, and Olav had briefly discussed this as well about all this population data. This is often a very big challenge where we have multiple sources of population data, whether it be ones that you calculate via your census that you estimate, and you compare this then maybe with survey data or other sources, or even within the same system, when there are multiple populations, it then makes indicators very difficult to compare across programs, for example. So if your malaria program is using a different denominator than your TB program, or any other program, it makes it more challenging to actually kind of compare these measures or contrast these measures because the denominators are not representative across these programs. All right, so before I proceed, I just want you to log into Mentimeter here, and I'll start this up. Sorry. Okay, so just go to menti.com either on your computer or your phone and enter in this code. Just take this out, start it up. Okay, some of you are responding already. That's great. But I'll just keep this up so everyone can join and answer the question. Okay, you'll see the question on screen and I'll go there in a moment. Over there. Okay. So is it difficult to train people on data quality? Okay, so this is the question. I'll just give everyone a moment to respond. Yeah, so I can see a lot of people kind of gravitating towards the middle there. And we'll discuss this in a moment. Keep these results in mind as we go through some of these concepts, okay? So we do have a couple saying yes. We have a kind of distribution here of responses, but the majority here in this middle box where they've kind of said it's somewhat difficult, okay? And we can kind of try to break that down a little bit and see why. Yep. Okay. A couple more responses coming in. They're fairly consistent. Okay. So do me a favor and leave this open. I'll ask you a couple more questions as we go through the session. Okay, so just leave this Mentimeter open. I'll refer to it in a couple other minutes, but keep these in mind as we go through some of the rest of the presentation, okay? Okay, so we're going to play a little game, okay? And it's very simple, all right? So I'm just going to present a couple visualizations, and all I want you to do is think about if any of the values look incorrect. All right, so we're trying to find out if there's any outliers in the data that I'm presenting. So first one here, what do you guys think? Have a look at the data. Is there anything wrong with any of the values? We're trying to spot any potential outliers or problems with the data that we're seeing here. Do you guys see anything? Yes, right? It's pretty obvious, right? Now, I wasn't trying to make it easy just to do so, okay? But we can see these green points, right? They're really out of line with the rest of the data, right? Yeah. So that's our number of ANC first visits, okay? And it's just kind of trending upwards, having these random spikes, right? So that was really easy to spot. So let's have a look at another one. What about this one? Is there anything wrong with this data? This is a dropout rate, okay? So some of you might not be familiar with that term, which might make it difficult. Okay, but what do you guys think? Is this okay? It's not okay, right? Well, what's wrong with the data? Okay, so for those who aren't familiar, okay, these negative dropout rates at the beginning, these ones here, right? Typically, this is problematic. There's many reasons why. We don't have to get into all of that now, but you can kind of spot that very easily on this type of visualization, right? What about here? Can we spot anything? It might be more difficult because of the slide. Okay, yes. So a lot of people said yes. Now just think about that for a moment and refer back to the previous question that I asked. Is data quality hard to train on? A lot of you said somewhat, and I would tend to agree with that, okay? But it is also our job to try and make these as interpretable as possible. We try to make it as easy as we can because this means other people can do this. So with no previous exposure, I just showed you a couple visualizations outside of DHIS2. Many of you were automatically able to engage with that visualization and identify a potential issue with the data that I was showing you, okay? So it is also kind of part of what we're doing. We're bringing all this data together. You can imagine now if we have TB, malaria, ANC data, all in one place, okay? And then we have to come up with ways to kind of mitigate challenges that we've had in the past, because those won't go away just because we're creating an integrated system. Data quality issues, they just won't disappear, right? They will still be there, except now we'll have them for many different programs, all in the same system, right? So it's also kind of part of what we're doing to make these or simplify these a little bit when we can, okay? So we try to keep it simple when possible, right? I know we can get caught up in the details. What is a normal distribution? What is a standard deviation? Okay, there are terms when we refer to data quality that can be difficult to train on a wide scale. But that doesn't mean we can't train others to help support this process, right? So I'm not trying to dumb it down necessarily, make it easy just for the sake of doing so, right? That's not what we're trying to accomplish, right? But we can make it a little bit easier so we can make routines easier for others to use. And by doing so, it allows more people to reflect on their information more frequently. And that is something that I think we can try to achieve, right? So if we're in particular training facility users or other users at other levels that may not have as much training in this area, that may not be as familiar with digital tools, that may not have as much background maybe in public health or biostatistics concepts, right? The idea is we try to make this kind of as simplistic as we can. That doesn't mean we don't need to build capacity at other levels to really understand how to utilize these tools, what these values represent, how they're created, right? So I kind of have an X here across this normal distribution. And for a wide variety of users, that can apply, right? But then there are, of course, that subset of users where you would want to show them, explain exactly what a normal distribution is, because maybe you're coming up with routines for measuring your data quality and they need to learn that. So that's why I tend to agree with that somewhat. When I ask, is it difficult to train data quality concepts? I could say somewhat, right? Because yes, in particular for that national team or that team that's really responsible for implementing these concepts, they should kind of learn a bit of detail, right? But then there are things that we can do to make it nice and easy, right? Without any previous training, without any previous kind of, just from your own backgrounds, you're really easy to kind of work with some of these visualizations, right? Okay, so let's look at another one. What do you guys think here? Is there anything wrong with the data? This one's a little tougher, right? So this happens. This is an example that I've taken from a visualization at the national level, okay? And we see a little increase, and we're not really sure just by looking at it. Is there a problem or not, right? Some of you are kind of thinking there's a fluctuation, but you can't really confirm if that's problematic. So in some cases, it can be more difficult to identify when these issues are happening, right? So in that case, we have other tools. So I'm just showing you here. So this is the value here in one district, in a specific facility for the same value, where we see this increase of 33,000, right? That's what's causing this increase, right? So sometimes you might need to dig a little bit deeper, right? So I say careful with sensitivity because in particular, if you're only viewing values at the national level, then you might get outputs like this, and it might look okay at first, right? But the moment you kind of dig a little deeper and check what it is, the cause of those values, then it can be a problem. And you do need routines to identify that. And in particular, this is why it's very helpful to have more eyes on the data, right? Because if this same chart were recreated within that facility, they would automatically see this big spike in their data, and they would be able to identify it immediately, right? So there are some ways that we can kind of help people along when we utilize these features. So it's not really just about the features themselves. I will describe those, but it's really about the routines that we try to implement to help people with this kind of thing, right? And what we focus on when we're showing them how to kind of work with these features. It doesn't have to always be so complicated. I'm going to keep kind of hitting that message home, okay? Okay. So shifting gears a little bit, I'm just going to discuss a couple of the specific features that we have available to review some data quality within the system. So here's an example of a scatter plot with various outliers. I think once again, you can kind of see, right? I won't say anything, but you can have a look real quick, right? If I look at this without really maybe even understanding, do you have some idea of where the potential outliers are? This is a bit more challenging, right? But even still, a lot of people were pointing to this box kind of over here on the side, right? So these two red dots in particular, right? So there's a lot of tools that we can use. This helps us. This does use some principles that we would need to understand, right? So how do we actually capture what the outlier is? You need to kind of understand the different methods that are available. So you set this up and it's not just spitting out nonsense, right? So someone does need to understand actually those different methods that are used. In this case, it's called the interquartile range, but you do need to kind of understand some of those concepts, right? Someone does at some level. But then when you present those, as long as you've kind of verified that what you're doing is correct, then you can share those with more people. And the more eyes you have on the data, the better I think the outcome will be. Okay, here's another one looking at completeness and timeliness. Now, what do you guys think here? Just looking at this, is there any problems? Or is things looking okay? I mean, would you guys be happy with this? Just focus on one line. I know it's kind of a lot, but have a look at the purple line, for example. It's going up and down and up and down and then up again and kind of like this, right? So sometimes there are other challenges with regards to this that we kind of have to consider. What actually happened? You know, what created this spike? Was it that more facilities all of a sudden came online? Were they supposed to be reporting the whole time and they haven't been? So there are other issues that are maybe kind of, when you think about the quality of your data, when you're looking at the information, that might be kind of directly impacted by other implementation related issues. As an example here, if you know, maybe if you're working in this country, you might have some more context as to why that spike happened, or as to why there's this fluctuation, why the same facilities aren't reporting every month. I think in most contexts, no one would really be happy with this fluctuation, right? Maybe, yeah, maybe. Maybe they're on vacation, maybe they're burnt out, maybe they decided not to submit, maybe they didn't want to sit there with the register. Could be any number of reasons, right? So sometimes it's not just like a entry error either, right? Like these are pretty, like this one's pretty obvious, right? Someone probably entered the wrong value. You probably didn't go from 400 HIV tests to 33,000 in 1 month, right? But as to why people aren't submitting the data all of a sudden, I mean, maybe you will know, maybe you don't. It might be worth checking with the facility. So there are kind of operational issues that are sometimes tied to this. It's not, you can't just really always just sit there. As much as we have tools to help with this, these are mainly meant to help you identify potential concerns with the data, okay? But that doesn't mean that you won't have other issues, operational issues potentially, that you might have to follow up with as well. This is just another example looking at reporting rate, looking at percentages instead of numbers. Okay, so a couple notes, and I mentioned these earlier, but I've just written them down just so you can get a good sense. So in DHIS2, when we're working with completeness and timeliness measures, okay, these are based on the reporting period of the data that you are capturing. So if you're capturing data every month, you're able to calculate completeness and timeliness measures every month. If you're capturing it every week, same thing, right? If it's more like an epi week that starts on a Monday or something, okay, same thing. So it's based on the week in which you're reporting that data. So, and then also I kind of mentioned this briefly, we typically apply these measures to aggregated data. So if you're looking at things like case-based data, or where you're reporting every case from a register, or every disease from a confirmed surveillance case, for example, okay, there are many ways to kind of collect that information, but it might be harder to apply measures of completeness and timeliness to that type of information. So just keep this in mind if you have maybe a current system or a current process for reporting completeness when you're trying to kind of think of how you would kind of get these measures set up within a DHIS2 system, for example. Okay, so validation rules is another feature within DHIS2 that we can utilize both at the point of entering data. So the user entering data could confirm their data. And we can also use it to analyze in bulk district data, facility data, and any level of data that you're capturing essentially, right? So we can use it both for kind of post analyses of the data after the fact, after it's been entered, and as well as kind of during the data entry process. So it serves kind of a dual purpose. And this is mostly checking, I'd say for the most part, especially during data entry, checking internal consistency. So within the data that you are submitting, you can create kind of simplistic rules. For example, the number of RDT tests, malaria RDT tests you perform shouldn't be more than the number of malaria cases that you report, right? So you can kind of go through and set up your own rules based on the logic of the data that you're collecting. And this, you can use both case-based data because you can aggregate the case-based data as well as aggregated data to create these types of rules. And you can also do similar types of checks when you're entering your case-based data if there are some kind of validation or logical issues with that information that you are collecting. This is just an example of where you can enter more information. So typically with these validation rules, we also recommend that you kind of add as much information as you can, a good description of why this is incorrect, a description even of what to do if this is wrong, you know, what does the person do now? What's the next step? Because, okay, I've identified that there's a problem. Now what, right? Okay. But this breaks down the various items that are contributing to this. So you can also combine multiple variables. For example, if you want to add 5 or 6 variables to give you a particular output and compare this with another variable or value. Closely tied to this, we also have this idea of sending notifications. We have to be a little careful here because you don't want to just keep sending notifications. It just becomes burdensome for the person receiving them. But if you can be a little bit selective in terms of sending these out, you can kind of say, well, this particular data quality issue now exists based on the validation rules we've defined. Could you please follow up on this issue? You can send these via SMS and email at the moment within DHIS2. So you can send those outside of the application. So maybe for someone like an M&E person, an M&E focal point, who maybe isn't logging in all the time, you can send these out and have them kind of access specific areas where there's problems. So these two in particular, they help a lot with this kind of idea of automated checks, because you can schedule this to run once a week, you can once a month, whatever, okay, and check your data and send out these notifications automatically when it detects there are problems in the data. Now, remember, you can also do this at the facility level, so the user can check their data as they're entering it, right? So it's kind of this combination of these two ideas. Okay. So we talked about outliers a little bit. There are quite a few different tools we can use to identify outliers. I showed just some examples of some simple charts. I showed an example of a table that kind of highlights the value in a red color, kind of gives you a good idea based on what you defined. We also have some additional tools that allow you to identify outliers based on measures like Z-score and standard deviation, for those of you who are familiar with those terms. Okay, we also have what we call kind of predictive analytics, and we use these to kind of identify, there are many use cases, I guess, right? For example, for thresholds for surveillance, you could use them. You could use them to identify potential outliers or problems with the data. With the data that you've received. So as an example here, I have this table up here, and you can maybe tell, but there's kind of like an obvious outlier here, right? This one here is 25,000, right? But right now it's showing me all the values, and I kind of have to look through it. It's not super intuitive or easy to identify. This is very obvious, but in some cases it might be less obvious. What we can do is actually just extract those values out that are problematic and give you a summary of those instead. So it's a different way of presenting the data, but in this case, I'm just showing potential problematic values rather than showing all of my values. Now, maybe this is not something everyone should see necessarily, but it does help you to identify specific areas where you might need to follow up, for example. And we can use some kind of specific formula that we set up to identify those values and then extract those and put those kind of on a separate piece of information for people to review. Here's another example here, and it's a little bit simpler to see. So we have the red bars here, which is our number of ANC first visits, and then the green bars here, which is the ANC1 threshold, which we've defined maybe some type of formula to allow us to calculate what that threshold might look like. And we're able to compare our actual reported value with our kind of threshold value. So if there are any values that exceed that threshold, then we're able to kind of figure out if something went wrong in that process. And we can also set up a comparison. So we could compare these values kind of on a routine basis. We could schedule that comparison, and then the system could identify or if there were any potential issues identified through that process. Okay, so within the DHIS2 kind of platform, we also have this additional kind of tool, this WHO data quality tool. Actually, Olav at the back and on will have a lot of information on this as well. I'm just going to show a little bit of it so you can see what it looks like. There are 4 kind of key measures that are identified within this tool. That is completeness and timeliness. I think we all have generally agreed what that looks like. Internal consistency, which is the comparing the data within your system that you're collecting. External consistency, where you're comparing data within your system with data outside of your system or collected via another process perhaps. And the consistency of population estimates. So just so here's an example of what this tool looks like. And we will actually talk a bit more about extensibility of the platform later on. But just an example that you can add kind of some more features and functionality in general to DHIS2 as a platform. It's not just relegated to what you get in the first place. Of course, we try to maintain and use those features as much as possible. But sometimes there are specific things that we want to do outside of that. So this is an example of when we first access the tool. And this tool, what we do is we basically tell it what we want to see. We tell it what kind of measures are acceptable or not. We tell it how to identify a potential outlier with our data. And it comes kind of pre-built with some suggestions for us to use. And we can modify those suggestions. We can kind of say, how many standard deviations away from a particular value do we consider an outlier? Various parameters like this. But it's all defined by the user, what we see here. So here's an example of completeness and timeliness measures. And we have a couple different programs, ANC, EPI or immunization, our routine HMIS collection form, maternity. Okay, so we're also, just like this whole idea of integrating our data together in one system, we can also look at measures for all that data together, right? We don't have to separate it out necessarily and do it all in separate pieces. Just some measures on consistency time. You would have seen some of this in the slides as well. We can create similar measures inside of DHIS2 as well. But just so you get an idea kind of this tool and what some of the measures that you can create look like. And this was the outliers table that I was pulling out and I used in some of the examples. You can see here, this kind of red identification of these outliers. It's very easy to kind of utilize and interpret it at least. And we have a number of pieces of guidance in terms of how you can kind of train people quickly on how to interpret this and use this in the field level. So within this tool, we also have kind of a summary of different kind of values and measures of data quality. So it aggregates all those different values that we were talking about on those 4 dimensions that I mentioned, identified earlier. And so completeness, timeliness, internal, external consistency, and our population estimates. And we can actually produce this kind of report. We're actually working on a small kind of variation of this as well to make one that's a little bit more flexible. But you can see here, for example, it outputs the various data based on what we've defined, and we can add, comments, interpretations, things of that nature, can print it out. And this does help, right? Because, for example, if I access this dashboard, it's not something that has to be done annually, right? That's the whole idea behind a lot of this. You could just run this check every month. If I ran this in the facility and have identified kind of several types of data values that I think might be problematic, right? I could just get the facility user to run this type of report at the end of the reporting period, and they'd probably quickly be able to identify some of the values that are incorrect. So it does help kind of facilitate some of this. The tools can help facilitate some of these processes at the facility level. Okay, so can you head back to Mentimeter real quick? I'll just ask you guys another question. Say it's the same Mentimeter if you kept it open. Yeah, let me just. I've changed the question, so in case you do want to answer it, you can. Oops, sorry. And here's the question for those of you who are wondering. We have clear procedures for managing data quality in our systems. So this could be DHIS2, this could be something else, okay? Just in general with your health data, do you have a process outlined for reviewing that data? So we have quite a few yeses, which is surprising. So I'm very curious to see what you guys have. Okay, but that's very good to see. Okay, so I'm going to keep it here. Okay, so a lot of you said yes. So now I'm curious what you include in those processes. Okay, what should you include in a data quality procedure? And for those of you who have ones written up, this should be very easy, right? I'll just give everyone a moment to write some responses. Okay, so we have quite a few responses here, and you know, they are varied, and I think it's quite good, a good representation. I've just listed some items that I might include, just so you can compare. I think some of them were missed. What do you guys think? Right, no one really talked about who's responsible for doing what in the system. Right, it was a lot about the tools. We should look at outliers. We should have some specific business process, right? That's all important, right? But when we have procedures, we really need to identify who's responsible for what, when should it be done, what is the timeline that it needs to be done, okay? What are the actual processes for changing these values? How do we follow up with facilities, right? All these kind of little details, right? The challenge that we often have, okay? I think this is one of the biggest challenges we often have when we're looking at data quality, right? I mentioned a lot of interesting tools, okay? A lot of different features you could utilize, right? And that is very good. I think it helps us facilitate, as I mentioned, it makes things a lot easier to expand the ability for us to review data in our system, right? But without clear procedures of what to do when we actually identify those values, it becomes very difficult to improve the quality of the information because we are able to identify the value, but then we don't know what to do next, right? So we just want to make sure that this ties together, especially now, if you're thinking more about an integrated system design. Like I said, you will have many programs data contributing to the system, right? And the last thing you want to end up with is a system where you can't trust the values, right? Okay. So I'm going to end it there because I think it's time for the break. But if there are any questions, feel free to grab me. I'm happy to discuss this with you further. Several of us are available and can discuss this area with you. I hope this was useful. Okay, if there's any feedback about the session that you want to change, we can do that. If you're interested in learning more about the features themselves, I think we could arrange a little bit of time to show you in a bit more detail how those things work, how the actual features work inside DHIS2 and how you can review them. All right, but we can take our break. I think, Alice, do we have the photo now? Yeah. Okay. So everyone stay in the room, please. We'll take the group photo. Yep. Can Hastings.
Yeah. Thanks so much for the presentation. Really very insightful. I have a question on the monitoring use of DHIS2. There have been many times where I've been asked to kind of provide, right? Yeah, to kind of provide statistics on the use of DHIS2, like how many people are able to access DHIS2. I've been able to retrieve that information. However, I've faced some challenges in terms of aggregating that data so that I'm able to split that, for example, District X, there were so many users that were able to access DHIS2 at a particular time. I was wondering if we have a feature in DHIS2 that we can take advantage of to retrieve such kind of statistics, because having these statistics in aggregated form provide problems, especially for programs where you are implementing in selected districts. Yeah, so so that's what I'm looking forward to, if I can be guided where to go in DHIS2 and be able to get or retrieve that information so that next time I don't have face such challenges.
Sure.
Thank you.
Sure. So there's kind of two ways that would be supported. I think one gets you halfway there, and then the other you might need a little extra push. So we have this feature in DHIS2 called usage analytics. This helps you identify how often people are accessing certain applications, what they're opening within those applications, etc. We also have some tools that Olav and the implementation team have developed that lets you know, for example, how many times certain charts are being opened, or kind of the usage of these actual items that are in the system. In terms of kind of getting some of that extra information that you're requiring, how many users per district are logging in, for how long, etc. There are maybe some other ways to go about that, maybe through either this API that we have, or the SQL by directly accessing the database. So I think we could probably show you some, or just mention, some resources for you that you could have a look at in order to generate some of those. So between these different features, I think they might be able to assist you in some of these areas. Yeah.
Thank you.
Okay, let's all come up and let's do the group photo, because I don't want to take time from your break. But if you do have any more questions for me, I'm happy to answer those whenever. Just grab me and we can set up some time for that. Thank you. This is the last, we need to record. What if I join Zoom from my computer? You guys can record it? You won't be able to explain it. Connect the HDMI port. I have a USB-C. Exit. Yeah. If I connect to Zoom, then you guys can record it. But why do you need to connect it there? You can just record via my laptop, right? Because you guys are still connected to the Zoom, right?
After the invitation after.
I'm here the whole time.
Yeah,
Till the end of the day.
Yeah. Once you connect, give you as a co-host.
It's my Alice and I share the account, so I'll be host.
No, the host should be us.
Oh, co-host. Yeah, I'll be co-host. Yeah, I'm just co-host.
Yes.
So you guys are host.
Yes. Will be priority two.
Yep.
It's recording as well. You're already sharing screen. It's good. You don't need the video, right?
Sorry?
Video.
No.
No. Sorry, I don't get your name.
Shuriji.
Shuriji. Okay.
Yes. Nice to meet you. Yeah. You could just let's do it. Okay, we're gonna change things up a little bit. I know you guys have been patiently kind of sitting, absorbing a lot of conceptual information. So what I've done in the Moodle system, I've added 2 more links. And what we're going to do, I'm just going to demonstrate a couple of the features that I was discussing before. I've given you links so you can follow along. I'll identify what those links are. So you can log in and actually get a better sense, for what some of these things are in the system itself. And then after we'll do an exercise. So no more presentations for today. Okay. And instead we'll do a bit more, hands-on. Okay. And if there are like, I know it's tough because it's a long day, but please, if there are specific items that you want, or just generally want to see more about how DHIS2 works, we can have some Q&A sessions afterwards. And we're happy to show you some specific features or walk through some demonstrations or just give you a better idea for how the system itself functions. I know we're not covering that so much during this academy, but we can talk to you separately about that if you have any specific questions. Okay, so for the first demo, I'm just going to cover, show you how validation rules works and some of the other features related to that works. If you click on this link here, analysis demo inside a Moodle, it'll open up a new, or sorry, it'll give you this link, I guess. Just click on the link. Okay, and then the login details are at the bottom of the page. Okay, I'm not going to go through a ton of features. I'm going to go kind of slow. You guys can follow along if you'd like, in order to just, get a better sense of how some of these features operate. Okay, so I'll give everyone a chance. Remember, it's on the Moodle page. So okay, it's this link here. Okay. And I just open it up and it'll give me the login details at the bottom of the page. So the first thing that I just going to kind of explain a little bit, and just so you can see it, how it operates, okay, is the validation rules. All right. So first, is everyone able to access the link? Any issues? Access and log in? Any problems? No? Okay, I see everyone kind of okay so far. All right, so I'm just going to explain how validation rules work, both when you enter data, as well as when you kind of want to perform this bulk analysis. Okay, and I'll just focus on that so we can kind of all see together. All right, so the first thing I'm going to do is navigate to our data entry app. Now, some of this might be new for some of you. I apologize if I'm moving slowly for those of you who are kind of already experienced in using DHIS2. I just want to make sure no one's left behind. Okay, so if I click on this kind of menu button, okay, this multi-dotted menu button in the top right corner here, I can access an app called Data Entry. This is where we actually enter all of our aggregate data. Yesterday, you used it in the exercise to enter data from your tally sheets. Okay. Just make it nice and big. Okay, and we interact with the hierarchy. None of this is different so far, right? All I'm going to do is select a facility, a data set, and a period. Okay, so I'll select this Cardinal Hospital, this immunization data set, and let's select, I don't know, September of, well, let's select maybe something a bit more earlier, February, maybe. Okay. So you select your data set, or sorry, your organization unit. In this case, I selected this hospital, this data set, which was immunization, and the period, which was February. All right. So when you're in this data entry interface, as people are entering data, aggregate data into your system, right? And you guys had a little opportunity yesterday to check this out and try it on your own. All right. So what this allows you to do, one way you can check some of the data quality before, at the facility level or at the point, I should say at the point of data entry in case you're entering data at a higher level. Basically, I mean, we're not going to enter any more data. You've already went through that. Okay, but you can run this, if you click this run validation button, it'll actually run any type of logical rules that you have set up for the particular program area that you're viewing as they're entering the data. Okay, so if I select this run validation button, it actually pulls up in my example, an issue, okay? And there's an issue with the stock in this case, right? The number is comparing the number of doses given with the number of vials that I've reported are used and wasted, right? It's saying that for whatever reason, I've used more vials than I've actually administered stock or administered doses of this particular vaccination. So this is an example of internal consistency. I'm collecting all the data within the same kind of process, same form, same tool, okay? And I'm comparing variables within that same form based on a rule that I've defined, okay? So all these rules, like this doesn't come, you can use these toolkits that we will talk about later on to bring in some of this validation, okay? But you can also, of course, define your own validation as well, all right? And we can run this, as I mentioned, at two levels. So one is here, I can run it at data entry and I can check and I can make sure I implement in all my procedures whenever a user enters data, they should click that validation button because they should actually check the data as they're entering it. All right. We have similar types of rules that we can set up at the point of entry for case-based data, where you can check, you can hide and show variables based on what they've input. You can indicate if a value is out of an expected range. You can let them know, for example, if they enter a BMI value that's too high or too low, or a weight value for a pregnant mother that perhaps is out of an expected value based on which trimester they're in. Other rules like this, where we can create prompts that allow a user to kind of immediately see, you know, if there's an issue with the data that they're entering. This allows, in this case, for example, I can kind of see what the error is, and then you would, you know, kind of show the user how to fix this, right? So if I go to the vaccinations I've given, so what is this again? DPT, Hep B doses given. So it's adding up all of these, right? And if I just increase this value a little bit, maybe it was 60 instead. Oh, I can't write. Okay, sorry, just let me log in as mine. Just so you can see. It's February. Okay, so I see that change value and then I'll run it again. Oh, hasn't registered. Change the stock. Okay, sorry, it's can't write the data. Okay, so the whole idea is that you're able to alert the user and provide some information as to how they can alter those values and update those subsequently, right? So you can try to catch some things at kind of the point of entry if you'd like. So what I want to show you is actually, you can also do this. So what I'm going to do, if you go to, if you're following along, if you navigate to this apps area, and I'm going to go to this app here, data quality, okay? And this is where I can run in bulk validation rules that I have defined. Yes.
So this is the dashboard for the people who are looking at the data as aggregate. Could we have a look about like what is the dashboard for the people entering the data? Would it be that complexity?
Data entry, not dashboard.
Yeah, so this is the data entry page, what we're looking at right now. Okay, so this is where they enter the data.
They enter it as an aggregate, not at the end.
Well,
of
it
the day.
depends. There's multiple models. We're just showing the aggregate data entry right now. They could also enter it as case-based data. But in this particular example, they're entering it as aggregate data.
So here's my question. Having this much as a huge matrix make the error higher, because you have the PCG, the DPT, all of them in the same high, and all of the slots or the cells are near each other. There's no next option. So will be confusing for the people who are entering the data. This is my high.
Yeah, this is just an example. You can change how it looks.
Okay.
Yeah, but I mean, many forms are kind of made this way in reality. We see many forms much less readable than this. But that being said, you base, this is just an example. You base these tools that they're entering data on your actual kind of data collection tools, right? So how they're configured, how they look, how they appear for the user, that's kind of based on your own implementation, your own context, right? So examples we saw yesterday, examples I'm showing now, they're just examples, right? You take everything, you localize it, contextualize it to your own setting to make sure that it works for you. I mean, you probably wouldn't want it all in English either. Maybe Arabic, for example, right? But all of these examples that I'm showing are in English. We do have other languages, French, Portuguese, but nothing in Arabic configured. But we do have other examples where you could use Arabic instead of English for everything that I'm showing, not just the data entry pages, but all the warnings, everything, right? Okay. So what I'm going to do is just show you how you can kind of analyze these rules in bulk real quick. All right, so I'll just go to this data quality app. All right. And I'm going to go to this first one here called validation rule analysis. Okay, so for those of you following along, it's just the first box. All right, so I'm actually performing this manually, but you can also schedule this to run on a period of your choosing. In this case, data that I was looking at was collected monthly, okay, I could have this run, you know, on the 1st of every month, or maybe the 15th of the next month, to give people enough time to submit their data. And then I could kind of analyze everything in bulk, and I try to identify any challenges or issues with my data. Okay. So what I'm going to do here, just because I'm doing it manually, there's a couple more steps. But if, of course, if you're doing it automatically, you would predefine which of these characteristics that you're selecting. I'm just going to select this unit, it's a fake made up place called Training Land. Okay, the top one here, it's in green. And what I'm going to do is I'm going to run this for 2022. Okay, instead of 2023. So I'll run it for the year. Maybe in practice, you'd only run it for a month. Maybe you would run it for a year if you're doing an annual review of some kind. Okay. Okay, so I'm just using the date selectors to select from January 1st to, I guess I could say December 31st of 2022. Okay, that'll run whatever rules I will select for the whole year. Okay. So what we do when we create these rules is we can create groups, you know, to put them together. That way we're not running maybe if you want to perform a check, you just want to run it for immunization instead of malaria, immunization, TB all at once, right? So the idea is we kind of segment those out. So if I select this box here, it'll have a kind of a list, in this case, of a couple different programs. So I could run just the rules that I've assigned to that particular program based on kind of a grouping that I've made. What I'm going to do is run it for this group called immunization thresholds. Okay. And I was showing you some examples of this predictive analysis in some of those previous slides on data quality, where you can define, you know, what your outliers look like. So what I've done is I've created an outlier for some of my immunization data. I'm going to compare the actual data that I've entered with the outlier that I've defined. Okay. And I mentioned, or maybe I didn't mention, but you can send a notification as well to a user to let them receive this data. So if I was running this as an automatic process, after the process was run, if nothing was found to be incorrect, I wouldn't receive any message. But if something was found to be incorrect, it would send a message to the users that I tell the system basically to send those notifications to. All right, so just to recap, I've input which kind of area, geographical area I want to analyze. I've input the dates that I want to analyze the data for. I've selected kind of the program logic or rules validation that I want to set it up for. And in this case, it's immunization. And I'm saying send a notification if you find anything wrong with the data. Okay. And even though I'm doing this manually, all these same parameters can be configured to run automatically, let's say every month, for example. All right. So
may I ask something?
Yes.
Here.
Yes, sorry. Yes.
So basically you can set this to run every month for each district or each facility, and the system is doing the automatic check of the data quality without the system manager interfering.
Exactly.
Wow.
Yeah. So you can set this all up to run automatically for, you know, various geographical units in your system. It'll let you know if it finds anything wrong. Yeah. But of course you have to set up everything initially, but once it's set up, yeah. So I'll just click on this button, validate, and give it a second. Okay, so it's output a couple items here, and it's given me a description. The amount of rotavirus, here, let me just pull up the details, I'm zoomed in. The amount of rotavirus 2 administered should be less than or equal to, this is not proper language, I apologize, I should really fix that. The mean plus 3 standard deviations of the last 11 months. That's how the outlier was defined, okay? So this is a particular, you know, you can make formulas to define your outliers, or you can just use other ways to bring in outliers into your system, okay? But because the amount of doses administered was greater than my threshold, it has identified some values that aren't quite in line with what I would expect, okay? And it's given me an output of this, and to the appropriate people, it has emailed them to me, okay? So this is my email now, and it sent a notification of all the different rules that have been violated. Okay, so we can set this up to be automated. You can send it to the users that are supposed to receive this. You can provide it with descriptions. You can see here I have specific names. They're made up places, but specific facilities. I have the month in which this violation was created. So I could actually go and check, I could follow up appropriately if I had some procedures in place. If someone receives this, of course, and doesn't know what to do with this information, that's problematic. But of course, if you set this up and then they have some proper follow-up procedure and they know what to do when they receive this information, it allows you to go in and modify values accordingly, follow up with facilities to ensure that the values are reported correctly, et cetera, et cetera. So this, I went through a number of features, but just to show you kind of hands-on, what this looks like. For those of you who were following along, I think, sorry, where was my? Yeah, you would have got here, okay? This is also useful because it allows you to review them within the application itself, right? You can pull up details and you can kind of see which value, as I mentioned, in some cases, in this case, I have 2 values contributing to the total number. I can have as many or as few values contributing to my total. Yes.
Yes, again, please, how flexible the rule creation again?
I'm sorry. Can you repeat?
How flexible? How much flexibility in the rule creation?
Yeah, it's totally up to you.
Based on what?
Yeah, so it's totally up to you in terms of defining the rules, right? As I mentioned, we have a number of predefined rules that we've taken with the guidance of partners like WHO, UNICEF, UNFPA, for some of the programs. That might be a good start, but you define the rules based on any mathematical formula you might have, any type of internal checks that you want to create.
Programmatically, or there is a user interface to do that?
There's a user interface. Yeah, this is also here as an example here. So I'm not going to go through all the steps, okay? But if you do have questions, we can go through it. But let's just see the outlier. RV2. Just open up one. So this is an example. You just go into this user interface. You can select which variables you want to be part of the equation. You add them in and you say, okay, this is what my value should be. This is what I'm comparing my values to. This is what the behavior should be between them. And it's all defined by you in this interface. And then you can save those rules and apply them to the program. And for anything that we're showing, dashboards, any type of analysis output, adding in data collection tools, okay, there's user interfaces for all of these things actually, okay? So there's not so much of a need, depending on the scale or what you're trying to create, to kind of, do something without an interface, okay? All of these operations that we show you have user interfaces to add these items. Yes?
Could the validation rules be determined centrally, not at the facility level?
Yes, so normally, I would say in a normal case, they are defined maybe nationally, and then the facilities use those. So the national level defines them for the facility. That's very normal, I would say. That's not to say if facilities have the capacity, they can't define their own and add them, but it's a typical case where there's a lot of national involvement in defining these rules for the programs, which also helps because there's standards to compare the data across the whole country. Yeah. Yeah, so there's not, like you typically only allow a very small amount of users access to these interfaces. Otherwise, it can create some havoc in your system. So it's really only people who are, we'll talk about this more later on, but people who have the right training, who are involved in the process, who really understand what they're doing. It's not something you would allow just anybody to do typically. Yes.
Yeah, it's just a comment on that one. Because those data elements being used for creating that validation is a data element being used by the whole users. So you can't allow users at the subnational levels, maybe at facility level, for them to create different visualization, data validations. In that case, users will be changing what has been created by other users. So it's good to give this feature for system administration, and RHIS system administration, in most cases they are at central level, but also there are some implementations depending to how countries organized. For example, we do have some countries which have a kind of regions or islands where they prefer to have system administration at each and every island. But in any case, this I think it's good to be created by system administration at national level. Thank you.
All right, so I hope that gives you some idea. Here we can I can show a little more, and then we'll kind of move on. So where am I now? Yeah. So I'm just going to go back. I'm going to head back to the data entry app. And we can select the same data set. Let's say February. That was the one I was working with. Okay. All right. So a couple more kind of features to help the user at the kind of site level. So if I'm here, and you know what, I've just gone back to the data entry app, selected my location, my data set, and my period again, and open that up. Let's open up the data set for me. And you can select any, if you're following along, you can select any data set, any period. Okay. If I just double click on one of these boxes, it's going to bring up this history. Okay. And this can also be helpful if we just show them kind of the basics of identifying, you know, trends in their information. If they see some huge spike again here, for example, you can put this on the dashboard too, but at least at the point of data entry, this also helps, you know, if people kind of just have a little suspicion about their value, because they'll be able to see, you know, like this is pretty consistent. I mean, there's some kind of ups and downs, but nothing really crazy. But for example, if someone hit 0 one too many times, so I can do that. Let's see here, for example. Oh, it's not registered. Okay. Yeah, so if someone hit 0 too many times, or you know, whatever, the value was inflated or too small, whatever the case may be, right? They would be able to see some of the dips and increases in these values as well. You're also able to kind of take note of who entered those values, right? So you can see, for example, this, I just entered this value now, has my name now, okay? If there are changes, so this is very useful if you have procedures for modifying the value, right? So if you note that there's an issue with your data and you end up modifying the value, okay, you can see who entered the previous value. You can keep track of then who modified the value as well, right? So if there's any kind of procedures around that, any type of approval or other kind of items that you need to look at, there is some information that allows you to track that information as well. Okay. Okay. Just really quickly before we move on, I'll show one or two more things that you could try on your own as well if you want. I'm going to be using this second link I've posted in Moodle, the data quality demo. Okay. So if either you want to follow along now or you just want to check it later on, we have a couple different demos for you to access. All right. So I'll open this one up. And same thing, you can just use the login details at the bottom, at the bottom of the page here. Okay, so I'll just log in with those. And this is where you can view the WHO data quality tool amongst other things. Okay. Oh, it's in French. That's okay.
Excuse me.
Yes.
Yes. Maybe I'm confused, but does it work as EMR, electronic record, health record management? Does it work
as an EMR?
Is it designed to work as an EMR, or is it a data analysis and reporting tool, yeah. Pure
Okay.
core.
Okay. So I would be careful in terms of how we classify it, right? So I would not say that we use DHIS2 as a type of patient interaction system replacement. I wouldn't say that it's kind of replacing a full EMR. It does not do direct hospital billing. If I'm consulting with a patient and I have no idea what their diagnosis is, and I want to enter in a bunch of notes, patient notes, I wouldn't use DHIS2 for that specific purpose. Okay.
Yeah, I mean, yeah, the life cycle of registering a patient, registering a visit for the patient, dispensing the medicine, follow-up appointment, etc.
Okay, yeah, for that type of thing, that's much more appropriate. If I have very specific services that I'm delivering, maybe I'm delivering certain maybe it's like, let's say it's an ART patient, for example. Okay, and they come, they receive their treatment. I want to know when they're coming back. I want to know which medicine I've given them. It's a very well-defined
patient
treatment
history,
protocol.
etc. Follow-up.
Yes, yes. Then in that case, you know, we can think about kind of case-based models for that. And we can use DHIS2 in those scenarios, but it is not a full kind of electronic medical record replacement.
Just again, for me to understand, I know there's a core functionality, right?
Mm-hmm.
And you can build on that. So,
yes.
So you want to build on that. What I'm talking about, yani, it needs a lot of customization or not, yani, or
right.
something.
So
on the fly, yani.
Okay, yeah. So there's two things, right?
How complex, yeah.
Right. There's two things. Let's look at it this way. I'm considering implementing DHIS2. Okay. When we refer to kind of localization and customization, this is not extra, like what I would consider development. We're not creating a new application. We're not kind of having to hire a bunch of developers, programmers. Okay. What we're doing is we're trying to understand for our context what health programs we want to implement, what data we're collecting, what indicators we need, what type of outputs we need. This is all configurable in the system without having to create an application, without having to kind of extend the platform. This usually takes us 80 to 90% of the way, but then there might be something missing, some type of custom report, some type of interface you need, some type of other solution. And in those cases, you might create like an application or something like this to extend the kind of features within DHIS2.
On top of it or something separate?
On top of it. Yeah.
Same system.
Top of it. Same system, just on top of it. It's a platform, right? And we're going to discuss this more in the coming days. But the whole idea with customizing DHIS2, it just comes as an empty box. We decide what we put in, right? So if you want to add stuff for your country, you add your facilities, you add your indicators, you add your data collection forms, you add your reports, okay? And that doesn't require some type of extra development work, I would say, okay? But in every context where DHIS2 is set up, we go through that process because, you know, it doesn't come set up with any of those things specific to any one country, yeah, okay? All right. Okay, so we're just going to switch over to a little bit. If you have more questions on the data quality features, want to see more demonstrations, please come grab us, okay? And we're happy to go through that. It's not a presentation, don't worry. We have another exercise for you to work on. And I think we've spoken enough about data triangulation for you guys to have an idea of what that is. So we're just going to do a little exercise to get you thinking about this a little bit more. Abdul Rahman and Haneen will help explain some of this in case I'm not able to convey it to you well enough. I'm just going to try and explain it to everybody. And then if you do have some additional questions, Haneen and Abdul Rahman will help me out. Okay, so I'll just open up the exercise. Okay. So what we're going to do, and just to go back, For this exercise, we're going back to the original demo that we set up. So we're going to use this demo for the exercise. Okay, the DHIS2 demo with the RHIS login. Okay. Okay, and let me go to that. Okay, so in this system, we have in this demo system that we've set up for you guys, we have two dashboards that we've set up that are triangulation dashboards. Okay, and what this means is we have data from multiple sources feeding in to all the outputs on the dashboard. Okay, so what we're going to have you do in this exercise is just review those dashboards a little bit and kind of think about in your own country, in your own context, what you could do to implement something similar potentially. All right, so if I go back. Okay, so I just list out all the instructions. I apologize, it's all in English, but like I said, Haneen and Abdul Rahman will be around and can explain a little bit more. Okay, so there's two triangulation dashboards that are available. One is called immunity gaps. One is called program performance. So you can access these dashboards when you log in to that RHIS login demo that we've set up. Okay, so these dashboards take data from three different places. Okay, one is routine immunization, one is stock, and one is vaccine preventable disease surveillance, both case-based data as well as aggregated data. All right, so what I would like you to do, I have 3 questions. Okay, you can open up that dashboard, just have a look, and you might want to do this in teams, in groups, okay, because different folks are going to have different input as to how to kind of interpret some of this stuff. All right. So remember, we're in this system, okay? The system link is taken from the course page, the DHIS2 demo, okay? That's where we're performing this exercise. So you don't have to follow along with me right now. You're gonna get chances to work on your own, okay? But there's a couple things I'd like you to do, okay? I'd like you to look at the items in the dashboard and try to identify where the data is coming from, okay? Which of these 3 programs are inputting into the different outputs that are available on that dashboard. So you might need a little bit of help from someone who's familiar with health, the health domain, maybe a doctor on your team, okay, who understands that process. Again? Okay. Okay, so the first thing we're gonna do, oh, that's better actually. Okay, we'll just log in to this system. Okay, the link is on Moodle. The DHIS2 demo with the RHIS login, okay? Okay, and I'm going to ask you to look at all the different visualizations on the dashboard called EPI immunity gaps and try to identify where that data is coming from. So, for example, I'm looking at a different dashboard, program performance. This is the second one. So if I look at this first one here, for example, I can identify that this data is coming from both case-based surveillance as well as aggregated surveillance. That's what this is representing. I have something down here that's coming from a different source. So what I want you to do is go through each visualization and try to identify the source of that information. Okay. Okay. Then there's a couple. Yeah. Okay. I think they can help you a bit more with the specific questions, right? So the next question is thinking of the data in your own context. So in your own setting, whether you have DHIS2 or not. Okay. Are there programs that you would want to present together in this manner? Okay, so are there kind of program areas that you would want to perform triangulation on? Okay. And then once again, thinking through your own context, your own country, at the moment, are you able to do that? Okay. So if you want to do that, are you able to actually set up analyses where you're combining information from multiple sources? Okay. And if not, then what are some steps you could take to kind of make this work in your own setting? Okay, so I would suggest you work in country groups. I think Haneen and Abdul Rahman will help me split up some of the teams. So you're made sure to distribute equally. But for those of you in smaller country teams, you can just stay together. Okay, You can have a look at the different components of this exercise. If there are questions, I can try to answer. And then as well, I've Haneen and Abdul Rahman are assisting me, and they will also be able to help you explain how to perform this exercise. All right. So I'll give you guys a little bit of time to work through this in country teams, and we'll go from there. Okay. Yeah, I can post the answers to you later, but we can also discuss a bit tomorrow.